And when we go further as well, we come back to that is a global phenomenon. It's not a specific to just developed countries. It used to be. But the impact of the minimal invasive is actually significant. This is a book that they say about the minimal invasive surgery in other area of the medicine, that the MIS has the same impact as advance of antibiotic. As a matter of fact, they say in the same book generally about minimal invasive, they say, just imagine after gallbladder surgery, patient would stay 4 to 6 days in the hospital. That would break our medical system. And yet for the spine, that is where we are. In the United States, in average, patients stay 4 to 7 days after spinal surgery, fusion, and so on in the hospital. And this is the reality of the spine surgery in Minnesota. So the University of Minnesota, this is a specific case, but generally, this is a one-level fusion that's scheduled from 10:30 to 17:30. This is too long, we know. For people who privately practice spine, this is too long, but this is not unusual. Even in the best private practice, one-level fusion being somewhere between 2.5 to 4 hours is actually the average. And obviously, we all have learned that it's not about the time. It's not about, you'd never speed a surgery. But we have to understand the time under anesthesia does have impact on almost everything that goes with the spine. And we are going to talk about spinal fusion in this presentation. And this study was based on 388,000 meta-analysis, independent even of kind of surgery you do. Every additional half an hour under anesthesia adds 17% to the combined risk of the surgery. It adds up to a point that if you put all the surgeries below 2 hours in one group and above 2 hours in another group, you will have doubled the risks of the surgery. Now, this by itself, many of our colleagues know that, especially in the younger people, may be all right. But when you get to people with chronic disease, elderly, patient with higher BMI, that is a decision-making process that practically exclude them from any kind of surgery. Now, I want to emphasize that, I'm going to jump forward and say that with the technology that we have developed, I'm talking about spinal fusion, scoliosis surgeries, and surgeries that are very complex. We have been able to practically perform 99.4% of our surgeries under 3 hours. As a matter of fact, 95% of them under 2 hours. Why is it important to do that? Because in the United States, generally, surgeries that are total anesthesia time less than 3 hours are suitable for surgery center. I can't just give you the information about the situation right now in the United States. It's extremely hard with the COVID to get my elective patients to a hospital. There are just no beds available. But I could do 2 levels fusion just yesterday in a surgery center. I'm sending the patient home less than 2 hours after the surgery. And being able to bring spine, which is a global phenomenon in that area, is a huge, important thing. Look at that. In 1990s, spine was number 3 for disability in the United States and is now number 2. Globally, in 1990s, spine wasn't among top 10 reasons for disability, and in 2015, it was number 4. So practically, the rest of the world is catching up with the development that we are getting older and our spine need more care. As a matter of fact, this data is for the United States, but globally, it's as well reflected that by the time you're 50 years old, there's only a 30% chance you don't have spine problem. And by the time you're 70 years old, there is about 1 to 2% chance that you don't have spine problem. Obviously, not all of them need fusion, but percentually, we are going to end up globally with more people that need spinal fusion. About every 10 years, we in the United States, we get together and we come to the conclusion spine is becoming unaffordable. It's going to break our health economy. and I come back to that. And every technology that so far have brought spine to a next level has added to the cost. Like you buy a robot, you have a $1 million robot and $100,000 yearly annual service for that robot, or a C-arm and so on and so forth. And I want to present you a technology that requires only 2 C-arm and a lots of surgeon skill. And we know in our part of the world, what we have in abundance is our skills. We may not have it, in some small hospital in southern Iran, money to buy a robot and a C-arm, but we have lots of skilled people, and the technology that I'm going to present to you, it totally relies on skills. I just told yesterday, I did 2 surgeries yesterday in my surgery center. I put it on LinkedIn. And the people who came and saw me watch me doing that, one of them was asking, why don't you use robot and so on? I told them that if it would add anything additional value, I would use the robot tomorrow. I'm very knowledgeable about those because I did a PhD in computer science. But as well, what I told them, I am using a very high-end computer. That's the computer between my ears, and I'm using the best robot in the universe, which is attached to my shoulder. You just have to train that. And I can guarantee you, and I have data to support that you can keep up with the highest technology just with your skills. Now, let's dive into that. We are going to talk about 2 techniques today, mostly about the oblique lateral lumbar interbody fusion, which is a transcambina approach. So we are not going to talk about the oblique lateral interbody fusion anterior to psoas, which you perform in a lateral position. I put both these the approaches for you together, and we use the same instrumentation, same path, same positioning. So for all practical, these are the same. The only difference is that you aim for one versus another to go anterior or posterior to the nerve root. Why is it important? Because the combination of that allows you to truly place the cage in any specific location, and the position that you put the cage, you have to plan for that from the start. But that allows you to as well correct for sagittal or coronal deformities. Let's come back to that. I'm sure Dr. Gupte will give us more information regarding that. Let's dive into that. This is MIS versus open surgery. We know it's not about the skin incision, what happened under the skin that makes the MIS, and give the benefit to the patient. Look at that here. This is an MRI 6 months after the surgery. All paraspinal muscles are actually scarred, whereas abdominal muscle are normal. You see that there? So we are creating lots of scar. We turn the muscle into scar, and you need to know this is multi-segmental, meaning that if you do in one segment surgery, if you do traditional surgery, 2 levels above the multifidus muscle are turned into scar because these muscles are multi-segmental. This is a patient of mine in 2012. I did a 2-level TLIF. In 2014, I did the adjacent segment OLEF, oblique transcambina OLEF. In 2015, patient had an accident, and I took the patient to the surgery. We all know, we all have been there, where we did the open surgery. This is not muscle anymore. This is just a physiologically dead scar tissue, whereas where I did the transcambina OLEF, because I avoided cutting and separating the muscle, this is pristine muscle that support the healing process. These are all the muscle we don't have to cut if we avoid posterior approaches. And this study is from 1930s that shows the vascularization of the bone, the vascularization of the vertebral bodies through surrounding muscle, and 75% of the surface of the bone is posterior. So in a traditional PLIF or TLF, where they taught me to go to the lateral gutter, we are reducing the vascularization of the bone to 25% of the original value. And now we are surprised that the healing is such an extended process. As well, I guess we are very familiar, especially our orthopedic colleagues. Imagine you do your shoulder surgery and you don't reattach the muscle in the shoulder. You know what the consequence of that is, but exactly that is what we do in the lumbar spine. When we do a posterior approach, we don't reattach the muscle. We practically prevent any kind of feedback for the muscle to know when enough is enough. So the transcamping approach has been around since 1970s. Actually, Dr. Camping just last year passed away, and it has been used predominantly in Southeast Asia for endoscopic approach, the extraforaminal endoscopic approach successfully. But our technology wasn't ever good enough to use it for fusion. And now I hope I can convince you based on my data that this is a daily routine procedure. The setup is very important. And I think I'm happy to have another conversation about the technical part of the surgery, which I think is very important. I practically tried all possible setup in the OR, and it took me 200 cases where we came with the setup in the OR that you have enough space to do what you need to do and more. We use C-arm in the AP and lateral in real time. And what we do practically do a measurement that give us an approach, an opening in the skin that we can go at 45 degree to reach the Cambin triangle. And we use a neuromonitoring probe. And the neuromonitoring probe, we use it with a 3 milliamp stimulation, continuous stimulation. We have electrodes in the feet, in the lower extremity muscle groups. If you are doing thoracolumbar junction, we actually put as well electrode in the abdominal muscle. And once we find the neurophysiologically silent area, at that point, I usually go to 4 milliamp. And then if I still don't get any stimulation of the lower extremity muscles, then the sleeve goes in, the stimulation device or probe goes out, a K-wire gets inserted, then over the K-wire, practically we put a dilator. Over the dilator, we put a tube. The tube is 10 millimeter outside and 8 millimeter inside. The first tool is a drill that opens up the space. And then a series of very smart tools are used to do the surgery. This is a very technical procedure. For that reason, what local hospital need is a 2C arm and a spine bed and a small tray. Practically, that is all a local hospital needs, because everything else comes in sets that are specifically made for this procedure. These are specific enough that you couldn't buy this. These are all made, custom made for this procedure. But on the good side of that, it has really very little stress in the hospital environment, because this set contains almost everything you need. The end result, this is from the time I used to use PEEK cage. I think like many of my colleagues, I started with titanium, went to PEEK, and now I'm back to titanium. Now we use titanium. And the process enables us to put the cage through those two approaches. We can choose to be posterior, be a true olive procedure, or anterior to the nerve root to be like a prone lateral. We published our paper with a prone lateral in 2017, and now we have been doing for 6 years literally prone lateral procedures. The combination allows you to put the cage front or back, right or left, and as you see here, the osteophytes are closed here and open here. That is where the correction comes. We have shown that in our study that we can correct 5 to 7 degrees per level with strategically placing the cage. So the cage here in the bottom one is eccentric by design, not by chance. Then always the question is, does the fusion happen and so on? We will come back to that. We have lots of speculation why fusion is happening in higher 98 percentiles. But I think my best guess on that is because we are not disturbing the vascularization of the bone. The end result on the x-ray looked like a TLF with a difference that this patient go home within an hour or two after the surgery. They go back to work within a week to in average, our patient go back to work within 1 to 3 weeks, and as well, significant reduction in the complication. Now, I'm not going to go through the data itself because this is a public on the PubMed. It's available. You can look at that. But I want to just pick up few of the results, including that the fluoro time is obviously going to be higher because that is where your eyes are. And even with considering the learning curve, the blood loss it was 1/10 of the open surgery. As a matter of fact, we measured the blood loss. We don't use BOVI, bipolar, coagulation, the suction. We use sponges. We weigh them dry and wet, and then that's how we calculate our blood loss. And hospital stay, meanwhile, I have data regarding that. We have the shortest hospital stay in the state of Minnesota, whereas average hospital stay in Minnesota for this kind of fusions are somewhere between 3 and 4.7 days. Our average hospital stay is 1.6 days. And again, yesterday I did one level fusion and one 2-level fusion. And both patients went home under 2 hours. Now, obviously, surgical time, even though we don't rush the surgery, it's just by design shorter because we don't have to spend time on separating the muscle, cutting the muscle, cause bleeding, coagulating, creating dead tissue, and moving forward, and so on. The surgical time is significantly reduced, and I can guarantee you the surgical time being reduced has nothing to do with my personal skills, but it mostly has to do with just the flow of the surgery itself. Now, even with my learning curve, see for my TLF, we compare that to my TLF. My learning curve for my TLF was 15 years ago. All my OLIF cases that are my learning curve are here. Even with my considering that, it is less risky in all categories than my own TLF procedure. I'd like to show you maybe 2 more slides or maybe a handful of slides. I'm getting close to my time, but this is a study, 380 patients in 1 year in one hospital, 5 surgeons doing regular TLF, and as you expect, when the BMI goes up, the time under anesthesia and time of the surgery goes up, and everything else what you don't see in this slide we looked at, including hospital stay, morbidity, mortality, pneumonia, infection rate, all correlates with the time on the anesthesia. If you have any question about the impact of the time on the anesthesia with the outcome of the surgery, just talk to your anesthesiologist. But as you see with BMI going up, the time of the surgery goes up, and as well, complication becomes higher. This is MIS-TLIF in the hand of a star MIS-TLIF surgeon who has done over 2,000 of these surgeries. Even in his hand at the BMI of 37, surgery becomes more dangerous, lengthy, and more complex. And here we could show that with transcameral lift, because it is tube-based, once the tube is in place, it doesn't really matter. We can perform the same surgery at BMI of 20 or 40 or higher. Meanwhile, we have done significantly higher BMIs, and people, nationally, patients are coming to us for this kind of surgery. Again, I'm not going to go through all these details, but all the data is available. This is one of my final the slides I want to present to you that shows 96% of our patients ambulate within the first 24 hours. That is why they can go home so soon. Again, I could not wrap my head around 10 years ago that in 2022, I would do 2 or 3 or 4 level surgery and send my patient home same day. And this is reality now. The impact of that, especially in our part of the world where the resources are scarce. I remember my father in Tehran had to wait 5 years for his spine, 5 years for his spine surgery. That is obviously many, many years ago. I know that resources are much better now, but still it's a factor. if you can do 6 surgeries in one room in a hospital and send the patient home same day or next day, or if you can do only 2 and keep them 1 week in the hospital, that will have impact on the public health, since spine is not a rare oncological disease, a rare blood disease. It's a public health issue. Now, fusion happens at a very high rate, and it's all reported in our paper, up to 98.7% interbody fusion. By the way, I was very critical of that, but other MIS, muscle sparing technique, has shown similar results. So this is not even unique to Olaf. Obviously, the learning curve is important, and but we know learning curve is in anything you do is important. You did not learn your TLIF or PLIF in a weekend course, and people who try to live this technique because it's different enough that it requires its own learning experience. People in the United States that tried to just go to a weekend course and come back and do it, only between 3 and 5% of the surgeon who got trained kept doing that, because the 95% of them gave up after 5 to 7 cases. We have good data on that. And the reason is always the same. The high rate of complication. Now, imagine you would send a surgeon for a weekend course to learn any, like TLIF or PLIF, come back and doing it at home. And I think this learning curve is what has prevented for this to really become more prevalent and more performed, at least in the United States. So I'm actually, I have a lot more to say, but I'm going to practically stop right here. This is just a paper just came out last month that shows people in the United States are waking up to this. This is a paper that they did 10 patient, 11 levels. I want to tell you what we have done. We have done 1,000. I checked it at that date, as you see, a few days ago. We have done 1,000. I have done 1,573 patients over 3,000 levels. This is 9 years experience with meticulous data collection. But what I have seen as well is that patient wake up and the leg pain is gone, the radiculopathy, the claudication is gone. So the question, if what other cause indirect decompression and I call physiologic decompression works, that question for me is answered by the patient. And if you just go to YouTube, put OLLIF and testimonials, you will find 1,000 patient testimonial at different stages that patients say, I woke up and my leg pain is gone. It doesn't really matter for me to dissect the mechanism of the leg pain is gone. But obviously, I do believe that physiologic decompression by anatomic restoration is the reason for that. But this is the fact that patient wake up, radiculopathy and claudication is gone. This is the case that we just recently did, a 3-level in 75 minutes with blood loss of 280. And I think what's really I'm proud of is not that I can do that surgery in 75 minutes, but I'm proud of that everybody who has joined us hit my landmark in 1/5 to 1/3 of the number that I needed to get there. Like I needed 180 cases to fall below 1 hour for 1-level fusion. Now people who join us, because they don't have to repeat my mistakes, they fall under 1 hour in somewhere between 20 and 30 cases. And I think that is something that says this is truly surgeon independent. This is just a new mode of surgery that is truly scalable. Now, I'm going to stop here, and you may have some question. I apologize going over my time, but I'm just going to stop sharing here and answer questions if there are. Dr. Yogi, you want to help us if anybody has a question so I can answer them? Or Dr. Gupte, did you receive any questions?
No, I haven't received any questions, but if nobody has one, I could probably ask this to you. You talked a great deal about the learning curve, which I think for new surgeons is always a question in mind. What's the learning curve for this? What's the risk of complications? How? And you talk really well about the number of surgeries you typically need, especially with the guidance from someone like you to kind of walk you through this to have good outcomes. So that was, I think, crucial for someone even like me to understand, what I may need to do. Because you're right, most of the surgeons will go for a course, will try to get the right patient candidate and implement it. And then with the fear of getting complication, obviously, we always as surgeons treat our last patient, right? We feel this and we're like, we're not going to go ahead with this. So I think the importance of the learning curve was tremendous, what you addressed. We do have one question, and after that, if you could address Dr. Abbasi, a small thing that I have is you have a tremendous, I would say, interest in education and having a global outreach for this procedure. What are your efforts in this field in terms of global outreach would be important to understand. But I think we have one question, and that question is from Santosh. He says, can you tell us more about the initial neural probe that you use? I think he's probably referring to NeuroMonitoring probe that was used for the procedure.
Yes, absolutely. Now, for people who are familiar with flying, there are two ways of flying. One, you use your eyes, and I think most of surgeons are trained for us to use our eyes, look at the anatomy, look at the certain landmarks, and proceed with the process, the next step. There is another way of flying. We call that instrument fly-through, that you get certain level instrument. Like when you get a flight, when you fly any commercial flight, they are not relying on their eyes. They are relying on certain instrument. And that instrument, they tell them what altitude they are, how far they are from where, and so on and so forth. I can compare this to the instrument flight rule. And we know instrument flight rule is about 500 times more accurate and safe than visual flight rule. So I'm not going to say any number about how much this is more accurate, but I'm going to show you this set. And in this set, let me just, not sure if you are able to see my instrument set. Are you able to see that?
Yes. Mm-hmm.
So this NeuroMonitoring is a crucial part of this. In the United States, meanwhile, I believe half of the spine surgeons use NeuroMonitoring, half of them don't. And in many cases, I would say, just be my guest. I always use it, but I wouldn't, fault any surgeon who doesn't use it. Some surgeons become very ideological about it. I'm not. But for this surgery, this is your instrument that tells you where you are. This is a specialized neuromonitoring probe. Practically, you put electrodes in the legs and in the abdominal if you're working on the thoracolumbar region. And all you're using it as you put a 3 milliamp stimulation signal on it. And you capture the data from the muscle groups to see if you're too close to the nerve root or not. It is insulated. If you see that there is a metal sleeve over the probe, so this is not part of the probe. The probe is insulated with a Teflon, and the tip of it is bare, meaning that is the only area that it can give the stimulation. We approach at 3 milliamp, and once we get too close to a nerve, then we just have to reposition. Generally, I use the pedicle of the lower level and let the probe drop in the Cambin triangle, but I keep that sleeve all the way back, so there is this about 1.5 centimeter area where the sleeve is above. But once I am in the proper location, I stop stimulating. I drop this sleeve in. Let me make it maybe a little bigger. So this sleeve drops in, and practically what it is, inside is 2 millimeter kind of hole that you can poke a put a K-wire and poke the K-wire into the disc base and practically create a path. If I may, I can as well show you in a YouTube video exactly how this step is done.
Dr. Abbasi, I think one of the follow-up questions with respect to the probe was: is it a custom-made probe, or is it a specific company that you use it?
No, it is a custom probe, but it's available. It's commercially available.
Dr. Abbasi, I would like to ask a question regarding the L5-S1 level. How do you tackle that level? Sometimes we have higher iliac crest, or sometimes we have large transverse process. How do you tackle that level? Like if we have higher iliac crest, then the direction will be oblique, and cage direction will be more towards the sacral end plate. So how do you tackle that?
Well, it's interesting you asked that, because I did yesterday this case, a 5S1 grade 2 spondylolisthesis. The question is how I approach that. I approach it with lots of experience. That's how I approach that. I start doing 5S1 after 40 or 50 cases. It has a different learning curve, because even more than iliac crest, the ala is in your way. And you have to add another angle to the approach. And I was very skeptical, but the reality is, it's like anything else. Once you get used to the instrumentation and the approach, you just have to have another approach, another angle to literally dive on the iliac crest and the ala. And let me just show you to perform this. I have actually picture. I haven't put, maybe I have put them online. I can look for you. But even more important than that, I can show you actually a video of that. If you guys just, and this is again available for everybody. If you just go to YouTube and I'm trying to, and just look for all of in the AP and lateral view, and just literally put OLLIF AP lateral. You get actually some pictures that you see the individual steps of that online, how it is done, AP and lateral view. This is a different one, but there are lots of actual, including for 5S1, how this is done in the AP and lateral view. So here is that, let me go back here. Here is the probe. It's coming, approaching. And let me just, so here, practically you see that the sleeve is in and the K-wire goes in, and the probe here, that's where you see the probe. If you just go after that, just put OLIF and X-ray views, you will get significant number of videos that shows you the actual steps. Okay, I'm going to unshare my screen now. Any more questions for me?
Just a comment, Dr. Abbasi. I think you have the most robust and large number of cases, and you have the most robust data to date right now. And I think it's very rewarding, very helpful for people like us, young surgeons who are trying to learn the MIS through this technique. So I think certainly learning curve is there, as Dr. Gupta mentioned, but I think we just need to have a little bit of more understanding of the anatomical landmarks of the cabins, and I think try the levels which are more easily identified with the right indications, and try that way. But certainly you can give the comments to the audience with your expertise, and I think people are eager. Seems like they're very eager to learn the technique, but the hesitation is because it's not there as as more obvious technique or as more common. So that's kind of the limitation for a lot of people not to have the opportunity to learn the technique.
Yeah, well, I just want to again emphasize that the learning curve for this is no different than when you learn doing posterior, when you learn to do posterior cranial decompressions. But the only difference is you did not go to a weekend course and learn that. Because we learned, we bring a lots of learning experience from our residency, generally it's okay to go to a course, additional course, and add additional skills. But because this is truly different enough from all the things we have learned, you need to deal with that as if you're going back to a mini residency, and the numbers is considering like probably a busy surgeon in the United States does like somewhere between 200 and 400 cases. Considering the numbers for that is 20 cases, and we can show that based on our experience, that is really not a high number. So, but still put a demand on a surgeon to take time off and from a busy practice and truly invest some time. But I can just tell you that it really pays off in no time, because you can take care of more patients, and you have to deal with less kind of post-operative complication and care as compared to a regular fusion.
Right.
So, okay, I apologize. I took a lot of time, but I want to pass the baton on Dr. Gupte now to Akshay, and I'm going to just pass it to you, and you can start maybe your presentation.
Thank you. Let me see first if I can share my screen, and let me know if you all can see my presentation.
Mm-hmm. Yes, we can.
Is it in full screen mode?
It's not full screen, but certainly we can see the slides, though.
Oh, yeah, we see.
Okay. Let me give me a second, guys.
Hello, friends, and welcome.
How about now?
I see it as a full screen.
Okay. So first of all, thank you for having me be part of this. I think it's an honor to be part of such an international community. Good morning to the folks back in India, to my colleagues and friends in Pakistan, and good evening to Dr. Abbasi and Dr. Janju. It's good to see you all again. My talk, it might be a bit controversial to some of you all, because this is some of the principles of deformity practice in spine that I'm trying to inculcate into my MIS practice, and it just of something that I wanted to talk about as to how I think of spine now, and perhaps we're heading there as a field, and perhaps it is requires more data about the exact evidence to incorporate this in future practice. But it's something that I think of, and I wanted to share as to how I think of these things. So I don't have any disclosures. The objective is just kind of going through the goals, the technical details of the radiographic dimensions, why I use these, how do I use these, and what do I exactly do in my practice. I don't have too many too many record details like what Dr. Abbasi presented, but this is something more anecdotal and something more personal to me. So what are my goals when I do any kind of spine surgery, right? All of us have the similar short and long-term goals, which is basically neural decompression to get relief or restore the function. We may do it in instrumentation or may not, depending on what the need of the patient is. We want a short-term enhanced recovery, which is less morbidity, short-term hospital stay, less blood loss, less operative time, less anesthesia complications, and then quick recovery and quick functional status. Now, long-term, we all want them to have improved functional capacity from where they were. We want, from an instrumentation standpoint, stable instrumentation, fusion across the process. But the other thing that I look at is, how can I reduce the risk of adjacent segment disease? Now, we all hear from our patients, most of our patients, even back in India, are scared saying, I don't want to go spine surgery because one spine surgery leads to the other. What does that mean? So that typically means adjacent segment disease, which is we're all unfortunately victim to this. But can we do certain things that will help reduce some of that risk? So there's a lot of literature that's been written about this specifically in deformity. And I know we have a talk coming up ahead for MIS and spine deformity as well. But I wanted to see is how I use this in MIS degen cases specifically. So why do I use this, right? So there's a lot of evidence that we see in different articles that talk about correction of lordosis and adjacent segment disease, even in flat back deformity patients. And even in MIS patients with degen cases, and how does the pelvic incidence, lumbar lordosis, and all these things kind of match up? So there's some evidence that's out there. I use that to my to kind of guide me. But how do I look at it technically? So just a quick, and I think perhaps most of you all already know this, but I look at lumbar lordosis, which obviously know superior end plate of L1 to superior end plate of S1. Some people use it to inferior end plate of L5. And then I look at the pelvic incidence, which is a constant number, which is the angle between the perpendicular drawn from mid-sacral plane and to the line connecting the femoral heads, the midpoint of the femoral heads. So that angle is the pelvic incidence. And in deformity literature, what's been seen is if the pelvic incidence and lumbar lordosis mismatch, which is the difference between the two, is less than or equal to 10, that's great. That's what normal is supposed to be. That's now where you want to be. And so ideally, every surgery that I think of is that's the number that I want to, that I kind of take into account. There's other things like sacral slope, pelvic tilt, but the most important thing that I think of is the mismatch. So what do I think of, right? Am I thinking of 6 degrees of Kevin Bacon separation? Sorry, that's a dad joke that even like my 2-year-old would not appreciate. But I think of degrees of correction. So I think of what is the pelvic incidence, what are the lumbar lordosis? Is it less than 10? If it is, then I should preserve it. I shouldn't do a surgery that actually makes it worse. So I look at preservation surgery, different things that help it. But if it's not, it's much more complicated. How do I get to it? Is there, anatomical considerations? Is there cage considerations, osteotomies, compressions, all those things? And mind you, in the context of MI spine. So how do I plan this? The first thing is obviously for most of us, we know, is the surgical anatomy. This is the absolute criteria that I use is, what does the anatomy look like? Can I get an A lift? Can I get a D lift? Can I get a T lift? Or PLIF? What's the ideal anatomy for this patient for that level that we want to address? Now, with that, if the anatomies kind of match up and different approaches match up, what kind of a cage can I use for this? If I want to improve the lordosis by about 3 degrees, what kind of a lordotic cage can I use? And does it have to be a specific degrees amount of lordosis? Does it have to be a specific width that I use? I also use the position of the cage. Now, where's the location of the cage going to be? If you're using a T lift, a PLIF, an A lift, again, I keep in mind that my location of the cage should be more anterior in the disc space with the lordotic implant in mind. Sometimes nowadays we have even expandable cages or interbody devices, which also help. I think of, is there a need for osteotomies? And with those, can I improve some of that lordosis even more? And there's even now pre-bent rods that are being manufactured, which are custom made for the patient. They're based on the spinopelvic measurements done for the patient preoperatively, and the rods are made based on that. And the idea is get the surgery done, and the rod should fit if you have the right angulation and correction done. So I think those are different things that I think of, and what do I do in my practice, right? So pre-op, first, I do a standing X-ray, which is a complete X-ray from the cervical spine up to the femoral heads. I make sure the patient's standing straight and their knees are extended. And with that, I use the lumbar spine and the sacral X-rays and the femoral heads to calculate my lumbar lordosis and pelvic incidence in a standing position. And using this, I then plan what I need to do. Obviously, I use the MRI, the CT for defining the different approaches that I want to use or I may use. I use the correction needed, then I decide on the approach. Intraoperatively, I have a ProAccess bed in my hospital that I use, which is basically a bed. This is my OR, and you can see in the midline there's a joint that is sort of robotic or can be adjusted. So this is a neutral position. When I'm doing a decompression, typically I'll put the patient in a flex position. And once I'm done with my decompression, placement of the cages, and right before I'm placing my rods, I'll get the patient an extension to create that lordotic curvature to get the amount of lordosis and the correction I want. And I'll place the rods and I'll lock the rods in. So I try to create that intraoperatively with the assistance of this bed, which helps in an MIS fashion. Then I use, obviously, I pay attention to the placement of the cages. I do measurements intraoperatively about the focal correction or focal lordotic angles that I want. And I decide about the compression. And then post-op also, I get standing x-rays for comparison and documentation and obviously self-review. This is something that Dr. Abbasi does immensely, and I respect and I follow him for that, is your follow-up for your own patients. And I think I try to do that is follow up how my patients have been performing, obviously clinically, but radiographically with their standing x-rays pre and post-operatively. So I know I kind of rushed through the talk and some of the stuff and references if you guys want, but I was more interested in discussing some questions if you guys have, because this is definitely not something usual that people think of, but something that I do think of and I try to incorporate in my practice.
I think it's a great talk, very nice sort of summation and summary of how you want your practice to be really evolved into. I think consideration of certainly Dr. Abbasi is the expert and senior. I mean, consideration of these parameters, the sagittal parameters, which have been, the data is really, been part of that publications, and data is so reminiscent of how these parameters are important and should be considered, in terms of the deformity patients for if you're trying to treat them through MIS approaches. I think I really like the bed you just mentioned, and Dr. I want to hear from Dr. Abbasi as well, how he thinks about that bed. We had that bed when I was at Penn, and essentially pretty much for deformity. And I think I wanted to ask you about the bed that that bed was different, it was really heavy frame. The bed you have right now, have you ever had any problem, people with certainly with high BMI, and I'm talking about people like, certainly we try not to operate on very high BMI patients, but if you put them probably looking at 40 and above, have you had any problem considering the angulation of the bed or where the hinge is? Have you run into any issues? I'm just asking because I'm kind of curious for future practice too, to kind of think about these kind of beds. And I was just wanting to hear your take. So I got excited when you showed the bed, and I think it's really helpful. And so what are your personal experience? Because it seems like it's like pretty much like Jackson frame. The bed I'm talking about was a very heavy mechanical bed, really designed to, entertain high BMI patients. So what are your thoughts on this? Have you guys run into any issue with the hinge or anything like that?
No, I think so. So this is, in my mind, a step ahead of the Jackson. It gives the same advantage of the Jackson, which is the abdomen is hanging, and so you have less of the venous compression and bleeding and venous bleeding. So that's a good thing about it. Especially great for high BMI patients because of the same factor of the abdomen kind of going down. You're right with the hinge. So I do pay attention exactly where their iliac crest needs to be and where that hinge needs to be. So I try to adjust it. I think this is meant for higher BMI patients. So the weight capacity is also higher than even for the Jackson. So it helps in that regard. I suppose if you have a really tall person with a high BMI, I think that would affect your probably at the angulation that you want to achieve because of the perfect bend. But most of the patients that I've had to work with, even though they've had high BMI, in fact, I love it for the high BMI because I use it even for discectomies because I can get a good, good lordosis and at the same time have their belly hanging down. So the amount of blood loss is minimized with that. So I actually use it most, and it has a flat version to it. So I use it for my cervical cases, thoracic, lumbar, for everything. Even if I do not need a correction, I think just the advantage of having that, the abdomen out of the way is really helpful.
If I may say, that is a fantastic bet. I have it in some of the hospitals, and but since we are talking to our part of the world, let's as well mention that is a $270,000 bet. That is not a cheap bet, Dr. Sharma. But you are absolutely right about every point you mentioned. And what I do in the places that I don't have that bet, I just use pillows to create what I need. So all of a sudden, I use a $70,000 bed. It's still expensive, but lots of pillows. But all the consideration, it just make it easier if you have a bed that does it all for you. Dr. Sharma, you have a question. Please go ahead.
Yeah, it's a very nice talk from Dr. Gupta. And, we do a lot of MIS, and we, in our practice, we look at the pelvic parameter for each and every fusion, and that we have been doing for almost 2 years now. And we have good experience with even the anterior approaches and even doing the lordotic cages. But what we have realized is not only the cages which really allows you to restore that pelvic parameter, it has more to do with the posterior releases. And that is how it has been. So even after doing a lot of big O-lifts and even putting those lordotic cages, so what we saw that we are not getting what we exactly wanted. And now sort of we have moved from working posteriorly, and even sometimes we do a single position surgery where we do the O-lifts and do in the lateral some of the releases. And I think that in our experience has really changed the practice. And so what is your thought process on that? Because I saw what we are talking about, and we have tried everything, but still there are times when we have failed. And now we feel that the posterior releases are as important as putting those big cases in.
I think, Dr. Sharma, you've hit the nail on the head. That's very important points that you've made, especially about the releases. And so one of the things that I mentioned was also the amount of correction that you want to need. So your planning is based on that, is how much of correction do I want to get. So the release also, the Smith-Peet osteotomies or the osteotomies will give you much more better correction as against to a lordotic implant standalone, as against to even the use of this bed. But even if we're not doing a posterior release, even just paying attention to these parameters, I think it's helpful to not actually make it them worse. That's what I talked about, preservation of some of these numbers. So I've seen so many P-lifts, even sometimes in my own practice in the past, that I've actually made their lordosis worse. Now, so I pay attention to that now. I don't want to do that. So now, even if I cannot make them better, can I actually preserve it? So that's another thing. So MIS approaches for preservation, but obviously you're right. If you want a higher correction, you want to get the posterior releases much better than just a standalone device.
So I completely agree with you. Even in my practice, it is measuring those parameters simply had just made us more aware, and we never realized there were times when you are putting those cages and you're fixing them, but maybe you are not making them where they want to be. And I think it's a very, very important thing. Maybe we also sometimes fail to achieve what we wanted, but it makes us aware that you are not there, and you try a bit harder every time, and you add new things, and you just try to go where you want to go. So thank you.
If I may make just one comment as well, and obviously spine is now much further than when I went to residency and learned that. And practically we never learned about these parameters in my residency. All of that came after my residency, and all of us have to be able to look at the data and learn from that. But I think something that one of my first teachers told me and put in my brain, I think I'm still going with that. I think patient's symptoms, the chief complaint, patient's problem is the first on the list. What I'm a little concerned about that in some practices that fixing the spinal parameter becomes more important than fixing the patient and patient's symptom. I can give you 24 of patients of mine who have horrible scoliosis, but they have L4 or L5 radiculopathy. I did laminotomy. I did foraminotomy. Their pain went away with a surgery that was like literally 45 minutes. So even though I think we are learning more and more and we have to include them, yet thinking about it is important, I want to emphasize that in my practice, patients' clinical symptoms come first. Everything else comes after that. But I think we are learning a lot from this new evidence. We are learning about them a lot, and we have to do in one way or another incorporate them in our practices. So,
absolutely,
yeah. Who's keeping track of the questions, and what other questions are out there for Dr. Gupte? I don't see anybody coming forward.
I think Bhavuk has a comment. Bhavuk, you wanted to comment something.
So I just wanted to echo your thoughts, Ayush, that the posterior, the bilateral facetectomy is actually, they become very important. And fortunately, I also have the Pro Access table with me. And we have tried everything. And, the best thing is the bilateral facetectomies, which help a lot in restoring the lordosis. And I think there is enough literature now that this OLIF doesn't help much in surgical correction. It is mainly for the coronal correction. So the thing is, the key is the bilateral facetectomies for restoring the lordosis.
Mm-hmm. Excellent. So I'm going to put the list on, and you just Dr. Yogi, you tell us who is going to give the next presentation, Dr. Yogi.
Sir, Dr. Bhavuk Garg is the next one.
Okay, can I share my screen? I think
just
Dr. Abbasi has to unshare.
I'm stopping sharing, so you can share your screen, please. Go ahead.
Sir.
So, my slides are visible?
Yes, it is.
Yes, thank you. So I thank the organizers for giving me this opportunity. And, people can talk about that they are very much okay with the freehand technique and they don't require these things. And then we at the other end, the robots, we can say that the robots, they are the extreme end. So I think everything is a way of seeing the things, in your way. Everything matters from the perspective. So that this thing, and in that case, the quest of spine surgeons, it has actually, started with freehand pedicular screws, and then we moved to the C-arm based navigation, and then to the O-arm navigation, and now we have come to the robotic, the guided spine surgery. So this is the paper, when we published in 2020 about when the robotic spine surgery started, and how we have ushered into a new era. So robot was basically first, it was used in a Russian play, and it was defined as a reprogrammable multifunctional manipulation designed to move materials, parts, tools, or the specialized devices through various program machines for the performance of a variety of tasks. So basically, any machine or any instrument which decreases the human efforts, you can call it as a machine or a robot if it is automated. But basically, there are 3 laws of robots. A robot must not injure a human being. It must obey the orders given it by the master, and a robot must protect its own existence. These are basically the 3 laws. And if you look at the history of robotics in the field of spine or the neurosurgery, it started with in 1985 when the neurosurgeons they started doing brain biopsy, and then came the Da Vinci surgical system, which was basically used for the general laparoscopic surgery. And in 2004, the Medtronics the Mazor came with the spine assist, and it was the first robotic system for the spine surgery to get the FDA approval. And then successor to the spine assist was the Renaissance in 2011, and which was later acquired by the Medtronics. So if we can divide the robotics into the remote manipulators, like we can do the telesurgery, then there could be passive robots. Then the surgical manipulations are guided by the surgeons. Then there are semi-active robots. When the certain stages of an operation they are performed by the surgeon, and the certain manipulations they are performed by the robot. And then there are the active robots when the complete surgical intervention is up to the control of the computer. So currently, the robots which we see, they are all passive robots, which we have. We have these main three robots. There are other varieties as well, but these are the main three. One, the Mazor X. The Mazor X is the from the Medtronics. The Rosa Spine is from the Zimmer Biomet, and the Excelsius is the Globus one. If we talk about the requirements, they can work upon three workflows. The pre-op CT is the main workflow, and it requires the fluoroscopy registration fixture to the C-arm just to confirm your accuracy during the surgery. And intraop CTs again works with all the types of robots. The intrafluoroscopy is available only with the Globus one, and it can work with the fluoroscopic registration fixture, and it has a special fluoroscopy module inbuilt into the Globus robot. So if we just compare the three types of robot, the Mazor X is basically fixed to the patient. It is fixed to the table, while the Excelsius and the Rosa, they are portable. They can move on the floor. So basically, I find this feature very useful. I have the Excelsius GPS. The reason is because suppose if I'm doing a big deformity and I just need the robot only for the apical screws, then I can just bring the robot in for that particular screws, and then I can move the robot out, when I'm not using it. So it gives me a little bit, the freedom to use. And the use of K-wires is again, it is not required with Excelsius GPS, so it makes it again very useful. The pre-op workflow, again, the intraoperative fluoroscopy integration is there, so you can just, if you're just doing MIS, then you can just do you can just use the fluoroscopy module, and there is no need of CT scan. The fully integrated systems, they are not available with the Rosa Spine, and if you look at the application-wise, the Excelsius GPS system is also FDA approved for the cervical spine and the navigated cage placement, again giving it more advantage. So these are basically the four, the major components of the robot. The one is basically called as the DRB array, the dynamic reference space array. These are the optical frames or this thing, and then we have the infrared cameras, which capture the position of these arrays, and then we have the rigid robotic arm, which has got the 6 degrees of freedom, and then we have this monitor on which we see this thing. So this is like first we get a intraoperative CT fixture over a spinous process or the PSIS, and then we use this dynamic reference base with trackers on it. And then we take an O-arm spin, and this DRB, we also place one more DRB at the PSIS, which is again a big advantage, because this is the advantage of Excelsius, that one can ask me, what is the advantage of our simple navigation? I have the O-arm as well, so why do we need this robotic system? I can just see everything through the navigation. The important thing is that the patient moves during respiration and all those things. So this robot has got a real-time feedback of this patient's movement, and if there is a more than 1 centimeter movement, between the spinous process and the DRB, then it can detect and it can warn you. So this is again a very good feature of this thing, and the robotic arm is a very rigid arm, so there is no chance of deflecting it from this thing. So if we take an O-arm spin, the DRB remain in place throughout this thing, and then after we remove the ICT fixture, and then we plan the trajectory in all the 3 sections for each planned screw. And then the end effector is a rigid robotic arm, as I told you, and which we can use the instrument through, and we can see the real time placement of the screws. So, and it also gives you a sort of the all the details at the end of the case, which I'm thinking for cervical systems, I think it is again very useful, this thing. And we use our DRB on the Mayfield itself, which gives it it's a very solid the no movement at all of the DRB in relation to the spine, and we just use this technology for the cervical spine, and we get good results. So coming to the robot, they have their advantages like any MIS surgery: the smaller scars, shorter hospitalization, lower risk for adverse side effects, faster recovery time, less pain, less blood loss, and quicker return to this thing. So proposed advantages are that the accuracy and safety is much more increased. So I'm not talking about 2 or 3 this thing, but if you look at the thousands of cases and then you look at the accuracy, then these robots, they actually stand a notch higher than the human hands. Reproducible consistency, reduced radiation exposure, it facilitates the MIS surgery, and you get the real-time information and feedback, and it ensures the navigational integrity, which is the most crucial aspect of the robotic advantage over a standard navigation thing. So robotics, they are evolving, they are combining various minimally invasive techniques. Now we can do the lateral lumbar interbody fusions in a single position with the help of the robotics. And we are also now at the confluence of evolving technology, and we are merging the artificial intelligence with robotics, and soon we are going to involve the augmented intelligence also, augmented reality also with the robotics. So we know that the pedicle violations can have great consequences, and there is a high rate of screw malpositioning in thoracic and the cervical spines. And people have compared actually the robotics, this thing, and they have found very high accuracy with the robotic placement as compared to this thing. However, there was 3 RCTs available, and 2 claim no difference in accuracy between the robotic placement and conventional, but again the sample size was quite less in this thing. So the automatic trajectory, if you look at, there is a less variation with the individual screws, and people have seen whether the seniority or the number of this thing, whether the surgeon is a senior or is a resident fellow, does it make a difference? And the residents, they could place as accurate screws as possible as by the senior surgeon. So you may require prior training with the robot-assisted spine surgeries. However, the learning curve is quite short, and the people have shown that the learning curve plateaued after the 30 cases, and people just with the minimum around 13 or 15 cases, they can get a good hold of these robotic-assisted spine surgeries. So radiation exposure is also quite less. It is needed only during the on-table registration, so only 2 shots. Low-dose protocols are used when intraoperative CT is used, and people have compared that, and they have found that the less fluoroscopy time with the robotic-assisted screw insertion as compared to the freehand. However, there is no difference in the MIS versus open robotic. People have also shown that they require just 2 images per patient in robotic, and also that time, most of your team, it can be out of the theater. There is a long time for setting the robot in registration, which a little bit increases your OR time, which I have felt, that with the increasing number of your cases, this goes down, with experience. There are general cost concerns. That is a prohibitive initial cost. Technology may become obsolete with time. It has got limited indications. It may not be useful in difficult trajectories. It may make young surgeons technology dependent. The research, it may be market driven. There could be some ethical concerns. These are the standard, the ethical this thing. But if you look at the specific concerns with the robotic, if there is a dislodgement of the reference array, so you have to ensure the adequate fixation onto the bone, as is with any other navigation, and you have to keep on checking the landmarks. If you cannot see your navigation tool intraoperatively, then you have to perform the tool check first. Look at the tracker balls. They should not be blurred, or not anything is hampering the recognition of these optical errors. Skiving or tool deflection remains a big problem with the robotics, but the robot, especially the axial, it can measure the forces other than the thrust areas, and it is an extremely rigid arm. So you have to just keep the robotic the alerts into your eye area, that it is not going undetected. And if there is an untracked anatomical shift, so they always insert your screws prior to any bone resection or the interbody fusion, and you always proceed from farthest from the DRB and then work towards it. So currently, the spine robots they are just only for the placement of the screw guides, and then they can also navigate the cage placement. However, they are not able to perform the rod contouring and insertion. They are not able to do the decompression, and they are not able to do the fusion as in current this thing. So to conclude, the robotics, they are coming a big way in spine surgery. They can be a big advantage for the minimal invasive spine surgery because they can enhance the surgery. There are less radiation exposure to the second and the other victims, not to the patient. The learning curve is quite short. But I agree that at present its adoption may not be so much wide. But once it acquires the ability of decompression, fusion, and complete instrumentation, that time the robot will come a big way in MIS spine surgery. Thank you.
Fantastic presentation. Thank you very much. I have a question. This system, are you currently using it in your practice right now? And where is that located right now?
So we have the Excelsius, the Globus One robot, and we are at All India Institute of Medical Sciences, New Delhi, India.
Okay. What was the investment required to bring that technology to your location? I know New Delhi is a multi-million people place, and probably you are performing in one of the best facilities there. But what was the requirement? How much did the hospital or the facility had to invest to bring that technology there?
So, like I work in a government hospital, and this hospital is the largest hospital in India, but it has got its own terms and conditions. So normally we, besides the cost of the robot, we also emphasize upon a 5-year warranty and a 5-year, the 5-year comprehensive repair, facility. So if we look at the cost of this thing, if I am correctly remember, it was around 90 million Indian rupees. This thing for the cost, and for the I think 2 or 3 millions for the warranty and the comprehensive repair system.
What would be in US dollar?
So US dollar is around 76 rupees. So I think it should be around maybe 6,000 or something, 60,000 or something US dollars.
Okay. So, I'm sorry, 60,000 US dollars to bring the.
So I think I have to let me calculate.
About 90 million Indian rupees would come to 1 million US dollars roughly.
Yeah, I think in the United States that the cost of bringing in is about 1.5 to 2.5 million, and it requires about $100,000 to annually for maintenance and so on. And I'm sure they make some special consideration, but we are still talking about significant investment.
Yes,
so
that's true.
That's great. In what? How many cases in a month do you use that robot for? I mean, you have to use it for a large number to make up for the investment, right?
Yes. So unfortunately, the COVID started, when we got the robot. So right now, still we are using at least 2 to 3 cases per month.
Okay.
Yeah, because of the COVID restrictions.
I see. Well, thank you so much.
I think
Neeraj has some question.
Oh, sorry.
Yeah, Bhavuk, I just wanted to ask, I know you since probably, you were in your residency. So you started with everything freehand, and then you started incorporating enabling technologies. You probably were front runners with this navigation. Now you are front runner in the robot. So how do you feel your practice has changed? Does it make really big difference? Because, we still don't have a robot. We are using navigation. And, I find that, navigation per se is not for all cases, considering our Indian constraints of cost and all those stuff, especially in private.
So Neeraj, I agree with you that I am still a freehand person. I am more confident and more fast with freehand technique. The only issue with robotic, I feel, is that the OR time is much, much more. But the thing is, now we have more operation theaters. So our output has actually increased because my resident can start with robotic. He can place all the screws. So actually, the amount of expertise required has gone down with the help of the robot. So actually our cases have increased. The number of cases we have increased. And so we are able to do much more cases now because the robot is there.
Yeah, okay. So maybe you can keep a watch on the residents, whether they are doing right or wrong by looking just at the robotic images.
Yeah.
Yes.
Yeah.
If I may make a comment, we as surgeon, I think we should use all the tools available to add to our expertise and to our skills. But the danger I see here, as you mentioned in your presentation and just now, is that we replace our skills with tools. And that the consequence of that, here in the United States, you hear that every week. The consequence of replacing your skills with tools and just taking the technology as a replacement for your skills are catastrophic in the United States. I just had a visitor here talking to me about cases that, now, obviously, we don't talk a lot about those really bad results, catastrophic results, but every single of them, when you go and look back, is when it happens when people try not to add the technology to their skills, but use it as an additional tool, but try to cut corners and use technology as a replacement for surgical skills. So I'm sure you will keep a good eye on your resident to make sure that you're adding it to their skills and not replacing their skills with that technology.
So Dr. Abbasi, I agree with you, that we should have all the tools in our armamentarium. And let me tell you about some scenarios, like I was operating in case of neurofibromatosis and, I tried my freehand technique first, but, nothing works because the pedicles, they were very, very thin. And then because this robot system has got inbuilt navigation also, you can just use it as a navigational tool as well. So I brought the robot and I just tried navigation. But again, because of the movement of my hands, the pedicles, they were breaking because they were a very thin channel. And then I resorted to the robot. And with the help of the robot, I could put the pedicle screws. So yes, there are certain cases, in which they make a lot of difference to this thing. So yes, I agree that we should be using every tool which we have to our advantage.
Dr. Garg, this is a great talk. Thank you for your, for stuff that you presented. I work in a county hospital in Texas, and we're trying to acquire a robotic system too. But the same challenges that we have is, and we've tried and tested all the products that you mentioned, but the same challenge that comes across is it's today, as of today, it's just a pedicle screw placing tool. As if it reaches, it has more applications, then perhaps it would have more weight to it, and perhaps that would be a good reason to get it. But I think we're not too far away from that to happen as well. So hopefully we'll get there soon. I have a question for you though. For what is your? I know you saw that you put the DRB frame on the Mayfield for cervical cases. Have you tried this robotic system for C1 placement of screws?
So my only experience in upper cervical spine remains with the Megrel's transarticular screw fixation.
Okay.
So we have done that.
Yeah.
Yeah, I think I'm just gonna say it's a certainly good talk, well prepared in terms of the comparison analysis of all the robotic systems out there in the market right now, and I kind of completely agree with Dr. Abbasi. Unfortunately, I used in training towards my tail end robots, and I'm sure Dr. Gupta might have experienced the same thing here. I think the limitations are, considering the upfront cost is the big issue, and then same thing, the indications or the usage is quite limited with only the pedicle screw placement. The accuracy and the advantage in the armamentarium of screw placement certainly is amazing. It's spectacular the way screws are placed, and the arm works great. But I think I kind of completely agree. I think in training, when we are training people, I think that's where the problem is going to be, because we have to show them different techniques from the pedicle breaks, and what are the other alternatives out there, what are the safe ways to put the screw with the lateral medial technique, how can we put the rescue techniques, how to rescue that index level. So I mean, in a nutshell, it's a really good it's really good that we are getting into a new era of using robotics, but I think we have to go a long way before we get to the stage where we're putting the antibodies and so forth, and then the upfront cost when it's going to be less. And I think that challenge is going to stay no matter where you are, because it's kind of very tedious to tackle that bridge upfront first.
You're muted, Dr. Abbasi.
I think, yeah, unfortunately, you're mute.
So, well, thank you so much. That was a fantastic presentation.
Yeah.
And I think Dr. Yogi is telling us that the next presenter is Dr. Vasavada.
Okay, so I'll share my screen. Okay, is it visible to all?
Yes, it is.
Okay, so my talk today is slightly different from what it has been presented so far. I'm going to go heavy on data and current evidences of minimal invasive spine surgery and deformity. Few of the points, how to use, what techniques to use has already been discussed. We have already seen cutting edge technologies in the previous talk. So we'll straight away go to my talk. We day in and day out, we start seeing this kind of patient as age expectancy is increasing, spine surgeries are increasing, and more adult patients are coming with different areas of deformity. So my talk basically will briefly touch upon basics of sagittal balance, what techniques we are using, and what are the current evidences for this technology. So spinal balance is a term where balance is a concept that describes a situation in which the forces or presence are more or less equal, so that your muscle has to work least and spend energy to the least so that your body can function optimally. Hominids modified that profile by verticalizing the pelvis, and gave that verticalization of pelvis gave lumbar lordosis and cervical curvature to have a horizontal gaze and maintain the balance. Probably initially the first concept of balance was introduced by Dr. Jean Debusset, and he introduced the cone of economy, that till the time our vertical axis or the center of gravity remains within this cone, inner cone, the muscle has to expend the least, and it can still tolerate till the outer cone. But the moment center of gravity falls outside of this cone, the body is no longer able to maintain the erect position. He also introduced the concept of a pelvic vertebra. We call it Debusset's pelvic vertebra. That pelvis is the deciding factor how your spine would curve eventually. How much is your lumbar lordosis, how much is your thoracic kyphosis, and how much is your cervical lordosis depends on spatial orientation of your pelvic vertebra. The pelvic parameter has already been discussed by Dr. Gupte, so we'll not go into much detail. But we want to take into account Rizzoli's curvature also. He divided normal lumbar curvature mainly in four types: low PI 1 and 2, high PI 3 and 4. And he focused more on the distribution of lordosis. He mainly focused on distribution of lordosis across the lumbar spine and inflection point of the lordosis to achieve a proper sagittal balance. And according to him, 2/3 of lordosis is at L4 and L5 junction. Then came a landmark paper from Frank Schwab, and he correlated radiologic factors with the pain or the poor health-related, quality-related outcomes. And he found that loss of lumbar lordosis, end plate obliquity at L3 and L4, lateral olesthesis between the lumbar vertebrae, and increased thoracic kyphosis are directly and strongly associated with poor ODI or disability scores among the patients. Cobb's angle, coronal, and age did not correlate with the symptoms much. He also demonstrated later on in 2013 that as the pelvic tilt, SVA and PI minus LL mismatch increased, the ODI also went up and up. And so the International Spine Study Group came up with a normal criteria that if your SVA is less than 15 millimeter or 5 centimeter, your pelvic tilt till the time it is less than 20 degree and PI minus LL mismatch is less than 10 degree, your spine is considered to be in a normal balance. With aging, this balance starts going. Loss of lumbar lordosis leads to pelvic going retroversion, increasing the pelvic tilt. And later on, the compensatory mechanism with hip flexion, knee flexion gets introduced. The moment body is no longer able to achieve this balance, the imbalance starts in, and they divided the patients into three groups: balance, hidden imbalance, and imbalance. Hidden imbalance where the compensatory mechanism can still play a role and try to achieve head over the pelvis position. And imbalance is when the body goes out of the cone of Dubusset. So what is adult deformity? We generally criteria are more than 20 degree of coronal curve angle, more than 25% of degree of pelvic tilt, more than 10 degree of PI minus LL mismatch, and more than 60 degree of thoracic kyphosis. The classification are still not universally accepted, but most universally accepted classification are from SRS Schwab. Schwab classification came into 2013, and they divided curves into thoracic, thoracolumbar, double curve, and later on introduced was isolated sagittal imbalance. As you can see, the sagittal modifiers are the most important parameters into this classification. And later on, very recently in 2020, Dr. Lenke, expanded his AIS classification into adult idiopathic scoliosis classification with lumbar modifiers and global alignment modifiers. Now, before we begin to go our journey into MIS in deformity correction, the Spine editorial in 2016 defined MIS procedures as the MIS procedures are the one that by virtue of extent and means of surgical technique results in less collateral tissue damage, result in a measurable decrease in morbidity and more rapid functional recovery while maintaining the same result or without the differentiation in the intended surgical goals. These are the number of techniques. We start from posterior open to MIS T-lip to lateral X-lips, O-lips, and finally A-lips. All these techniques can be performed through minimal invasive way. So broadly, the strategies to treat ASD into adult deformity are threefold: open surgery, circumferential minimal invasive surgery, and the hybrid surgery. Open surgeries are traditional posterior approaches where we can do traditional open surgery, can do our osteotomies. Circumferent minimal invasive surgeries are employing anterior as well as anterolateral approaches and posterior percutaneous fixations, and hybrid are where the minimal invasive anterior or anterolateral surgeries are being performed and later on supplemented by posterior open surgery to correct the residual deformities. So let's take and compare all these three techniques. And I would want to present a paper from an international spine study group, and they compared all the parameters preoperatively, postoperatively, and the change. And as you can see that post-op parameter or change when you can improve, MIS has least change as compared to open or a hybrid, including lordosis, SVS, pelvic tilt, and thoracic kyphosis. So in a nutshell, they says that circumferential MIS selected for a lower sagittal malalignment. If your patient is having higher sagittal misalignment, more extensive surgeries like hybrid or complete open surgeries along with osteotomies might be needed. Finally, they concluded that there is no statistical difference whether you use MIS surgery, whether you use hybrid surgery or an open surgery. In patient-reported outcome, there was no statistical difference which was found. But if you look at the surgical variables like estimated blood loss and OR time were least with minimal invasive surgery, while OR time was increased with hybrid surgery, transmission requirement was least with circumferential MIS surgeries, and rate of major complication was highest in the open surgeries. When you do MIS surgery, the interbody procedures are increased as compared to open, leading to more fusion, better fusion, and early fusion in our patient. If we compare the complications following the Glassman's complication classification, circumferential MIS has the least number of complications as compared to hybrid and open. If you look at the absolute numericals, although difference could not reach statistical significance in their paper. Now the question comes, if we operate through anterior surgery and we rely most of the cases onto indirect decompression while doing a circumferential minimal invasive surgery, what if our patient wakes up with radiating pain? That is the question time and again we surgeon ask to ourselves and into our meetings. So the Anand group came up with a stage protocol wherein they first operate the patient anteriorly, and finally after a few days they come back with for the posterior fixation. They devise a protocol wherein stage 1 they do oblique O-lips or A-lips, and they assess the patient radicular pain for next 2 or 3 days. They take the patient back inside depending on their sagittal and coronal profile to perform either only percutaneous fixation or adding minimal invasive T-lip or a hybrid procedure so that optimal correction of SVA and PI minus LL mismatch is
restored. If we analyze complication of this staged procedure, when you do a circumferential minimal invasive, absolute minimal invasive procedure, there was no change in complication rate between a single stage or a stage procedure. But when you compare the hybrid stage procedure with unstaged hybrid procedure, the complication rates went up with a stage procedure. Minor complication as well as radiographic complication also went up. So how to decide the strategies to treat our ASD, whether we should go for decompression only, whether we should go for open surgery, should we go for circumferential minimal invasive surgery or a hybrid surgery. So MISDAP algorithm was given by Momanani et al. Group from ISSG way back in 2014, and they divided the patient into three classes. Class 1 having minimal sagittal imbalance, class 2 having moderate sagittal imbalance, and class 3 having maximal sagittal imbalance. And they said that class 1 might require single level or just a disease level fusion or a decompression. Class 2 might require curve fusion from end to end, and class 3 might require open surgeries with osteotomies. They also further came up with an algorithm that what levels to be fused and how to fuse. And they concluded that for L1 to L4, the surgeons preferred lateral approaches and reserved the minimal invasive anterior column release for patients who needed greatest increased sagittal lordosis. For L4-5, generally the anterolateral or an ALIF is preferred over TLIF to restore significant lordosis. L5-S1, majority of the surgeons these days in deformity correction prefers anterior surgery over TLIF because it is said that TLIF cannot produce adequate lordosis. However, a nicely done TLIF, nicely released TLIF can still restore a good lordosis at every level, and it is probably a more familiar approach to most of the surgeons. Very recently in 2020, with advanced in the minimal invasive surgeries, again the Momanani group came up with the MISDAP2 algorithm, and they included most of the rigid deformity also into the minimal invasive flowchart. And they again divided in depending on Cobb's angle and PI minus LL mismatch. If PI minus LL mismatch is less than 10 degree, go for class 1, class 2 surgeries, where is complete MIS surgeries. If it is more than between 10 to 30, you may have to decide about AACR or anterior column release depending on your expertise. And when the PI minus LL mismatch is more than 30 degree, opt for open surgeries, including osteotomies, as per the Schwab osteotomy classification. Just for example, class 1, where sagittal malalignment is not so much, go only for decompression. Class 2, where moderate sagittal imbalance, go for a curve fixation from end to end vertebra. Class 3 might require osteotomy, which may be minimal invasive or open depending on the surgeon's proficiency. Class 4, 100% requiring almost open surgeries in majority of the cases. The next question comes while doing or dealing with minimal invasive surgeries. Does it reduce the chances of proximal junction kyphosis or a proximal junction failure? Because that is the nightmare for any surgeon who is operating deformities. So the Yuan Orbe group came up with a paper, and they said that if you keep your surgery simple, the chances of PJK is much less. So LLF, LLIF, isolated LLIF is much less prone to have PJKs and PJFs as compared to LLIFs, ACR with PCOs. This clearly denotes that if you have to restore your sagittal balance more, like changes of SV or LLPI minus LL requires much more correction, your patient nevertheless would lead to higher chances of PJKs and PJF. However, PJKs, PJF were lesser in numerical values as compared to open surgeries. If we compare surgical factors, any surgery which has gone up to thoracolumbar thoracic region has higher propensity of having PJKs and PJFs. So what are the factors that can affect approach selection, whether you should go for MIS or open, barring the algorithm part? So majority of the surgeon says that as the age progresses, the advance in age, MIS surgery was chosen more over the OLIF, while need for decompression, higher scores of back pain, higher score of Cobb's angle and other parameters, surgeons wanted to choose open surgery over the minimal invasive surgery. So age and back pain, and need of decompression, coronal angle, and thoracic T1 pelvic angle were the criteria to choose open surgery over MIS surgeries. Now, what are the factors in MIS surgery in patients who does not get desired result or patient dissatisfaction or a failed surgery? So majority of the patient had an idiopathic cause for failure or dissatisfaction from the surgery, apart from degeneration, progression, structural or implant related. complication. So the next question and last question comes with, if a patient is having high amount of sagittal imbalance, should the MIS procedures be still performed? So again, the Urbe group came up with the patient and they divided the patient into low pelvic tilt, high mid pelvic tilt, and high pelvic tilt patient. And I'm sorry for the busy slide, but I'll try to simplify this slide. If we compare all these three groups as per the radiographic parameters, all three groups following a MIS procedure, following MISDAF criteria, achieved a significant change in the pre and post-op parameters. But when you look at the post-op parameters in mid pelvic tilt and high pelvic tilt, there was significant residual PI minus LL mismatch, or a radiological mismatch was still found. If you look at the PI minus LL % success, which was probably the least in mid pelvic tilt and high pelvic tilt group. But if you compare the patient reported outcome with VAS for leg, VAS for back, and ODI, there was no significant difference. So they concluded that despite there is some residual aspect of sagittal balance in patient with mid pelvic tilt and high pelvic tilt, there was no significant difference between patient reported outcomes and the complication rate. So there comes the role of a global alignment and proportionate score. So the European Spine Study Group, they did an extensive data analysis and they came up with overall radiologic and implant related complication was 31.7% in this group. But if you try to achieve a near normal Schwartz criteria, then the implant related complication may go as high as 52.6%. So why this can happen? Because Schwartz classification does not take into account, there is always a distribution of lordosis and possibility of having a negative SVA in some of the patients. It also fails to take into account 2/3 of the lordosis distribution must be at L4-5 and L5-S1. They also says that large PI will have large pelvic tilts, very low PI will have a very lower pelvic tilt. Hence, if less than 20 degrees is not ideal for high PI, because high PI will naturally have pelvic tilt. So you cannot apply the rule of less than 20 PT is normal in high PI patient. So that's where the gap score came, and they took into account relative pelvic burden, relative lumbar lordosis, lordosis distribution index, relative spinopelvic alignment, and the age. And they differentiated these patients into three groups, one aligned group and three disproportionate groups. So they calculated relative pelvic version. And every version has three things: severe retroversion, moderate retroversion, aligned and anti-version. As we compare relative lumbar lordosis, they are distributed into severe lordosis, moderate lordosis, aligned and hyperlordosis. Lordosis distribution index was classified into severe hypolordotic, moderate hypolordotic, aligned and hyperlordotic. And similarly, global tilt was also classified into severe positive, moderate positive, aligned and negative. Age were only distributed less than 60 or more than 60. Based on this criteria, they came up with a scoring. And if your score comes between 0 to 2, your patient is proportionated after the surgery. If it is 3 to 6, it is moderately disproportionated. And if it is more than 7, it is severely disproportionated post-operative radiologic result. And the patient with moderate or a severe has a higher chance of implant failure. So if your patient is into range of proportionate or a range of aligned parameters, your patient still can withstand some amount of sagittal imbalance and should not be following strict Schwartz criteria. So in conclusion, MIS is still an evolving procedure. Majority of the surgeons these days, they prefer to employ MIS techniques for mild to moderate type of sagittal misalignment. Still requires open surgery, including various osteotomies for advanced or a higher amount of sagittal malalignment. Thank you so much.
Well, thank you so much. That was a very comprehensive presentation. And I think that the classification are very well presented. Dr. Yogi, you want to present if there are any questions before we move on to the next speaker?
No, sir.
So, Neeraj, can I ask a question?
Sure, Bob.
So this gap score, this is from the Turkey group. They came with this to decrease the chances of implant-related complications.
Yes.
Now the same surgeons, the same group of surgeons, they are coming up with more strategies like multiple rod techniques, and this thing. So what do you think? They are not satisfied with gap score, even if they are able to achieve the proper alignment. They are going for multiple rod and all those things.
Well, I guess, spinal deformity is still an enigma. Those who are operating spinal deformity, I think everybody of us know that, we would not want to operate because, whatever we do, your patient might be going for a failure. Majority of, if you look at the literature, they report complications ranging from minor to major, almost ranging up to, I have heard Dr. Chapman saying once that, the complication rate of, if you try to calculate almost literature, the complication rate goes up to 80 to 85% in majority of the cases. So I guess, we still have not understood the aging. We have not taken into account aging while, devising all these protocols. We are still, blindly, as Dr. Gupte said, we are still trying to follow the sagittal parameters, forgetting the clinical need of the patient. And probably that has led to a new pandemic of this multi-implant construct. So I guess, for me, first and foremost thing to select a patient for degenerative is patient's requirement. I think, I still don't blindly follow the sagittal parameters, primarily a patient for which patient has come to us. The more you do, I think the dictum which we have heard more often, first surgery is always an optional, second one is not. So I guess we need to take this deformity surgeries with pinch of salt. We need to select our patient very vigorously and very strictly.
I agree. There's no condition which cannot be made worse by the surgery.
Correct.
Thank you.
If I may just make a comment here, my colleagues, who is orthopedic spine surgeon, Dr. Kim, who is unfortunately not online with us today, he's a deformity surgeon for 35 years, and he and I, we had a conversation. We put it online on YouTube as well. If you just look up Dr. Inspired Spine, Dr. Kim, the deformity parameter, he explains as well, very along what you're describing, that we have to choose and select the patient group that this parameter should be more or less. When we apply this, we have to be selective. You have to put more thoughts into how we are going to apply this selection. And I think that what you need there is lots of experience. I think that's certainly, as Dr. Gupta said, we always treat our last patient. But I think this is one of those things that if we bring protocolize it, if we bring lots of experience as well, we look at lots of evidence, we can come with a better way than just blindly follow numbers or treat our last patient. But that was a fantastic presentation. Thank you very much. So, Dr. Yogi, I think you are telling me that the next presenter is Dr. Sharma. Is that correct?
Yes.
Yeah, so thank you very much, and thank you, Dr. Yogi and Dr. Abbasi, for giving the opportunity. Can you see my screen? I guess you can see it.
Yes, we can see it.
So let's move on to something different in MIS, which is the endoscopy spine surgery and the new kid in the town. Not new, but one of the most talked about things today when it comes to MIS. I'm Dr. Ayush Sharma. I'm a consultant spine surgeon in Mumbai. So this is my disclosure slide. For many years, I have been a tubular guy, and I have a lot of experience with tubular. And recently, for the past couple of years, I've been flirting with the endoscopy experience, and it has been a pleasure, and it has been a wonderful journey till date. So this is how I see when it comes to my 10 years of experience in my surgery. This is how I used to do it when I started. And it is like digging a pond, and you dig a pond and you reach the spine and do your surgery. But if you want to drink water, there are many ways to drink water. You can dig a well as well. And so we moved on to the tubular system, where you put a small tubes, you reach the spine and do your work. But if as you go ahead and you become more adventurous, you want to go up close and personal, and you want to see the spine more closely. And this is how I see the endoscopy surgery. And as you see, as we have gone ahead, not only the complexity of the technology, of course, has increased, but so has your visibility and so is the fun of doing the surgery. So, as most of you are well aware, there are two ways to do endoscopy. You have interlaminar approach and the transfemoral approach. So I'll just briefly go through both of them. Interlaminar approach, you go in between the lamina, you use the natural corridor which you have through the lamina. It is something for anyone who has, someone like me who has gone from open to tubular to endoscopy today. It's a familiar approach. And again, at the same time, it is a very, very versatile approach because you will be able to almost tackle almost everything with this. So just to give you a brief idea about the interlaminar approach, so you use the natural corridor between the lamina. You use endoscope, which could be depending from 8 millimeter to 0.3 millimeter. And as you go, you will get the muscles, and you just take out the muscles, and then using the RF probe, and then you come to the ligamentum flavum. And this is how it is, whether you are doing open surgery or tubular, and you cut the ligamentum flavum. So here, depending upon which part you are approaching, but as a rule, mostly will go from the medial to lateral, and then you simply dilate the ligamentum flavum. You don't even need to cut the whole of the ligament flavum. Of course, it depends upon what type of procedure you are doing. So this is what we are doing. And once you have make enough of the window, you get the fat part, which is again what you get normally, whether you are doing an open surgery or a tubular surgery. And then you identify the neural structure. As you can see here, we have identified the lateral most corner of the dura. And then depending on the pathology which you are tackling, you go about it. So for example, in this case, we have identified the root, and so let's see the different scenarios where we use the different things. So as you can see the root here, and you can see the dura. For example, this patient was a 20-year female with only a radiculopathy, and you can see the disc is on the left side. So we went just lateral to the root. So and we did the discectomy, and we came out. So you just went lateral to the root, which is because the disc was there, and this you can see the disc fragment coming out here. So this was a case where you had the pathology was, and this is how it looks like when you are doing the surgery. So this was a case where the pathology was not central, but the typical case of radiculopathy. So you and this is at the end of the surgery. You can see how the root is completely free. Now look at a different scenario. Here the patient has a bilateral radiculopathy, and you can see this is more of a central disc. Now if you see again, the endoscopic interlaminar approach was used, but instead of going lateral to the root, we went through the axilla of the root because that was much more easy to approach. And we did the same job. We did the discectomy to the axilla of the root. So that is the advantage of using the endoscopy, because you have a very, very small portal, and it is very, very easy to approach the way you want to. But again, it's very, very important to understand before you put your scope what you are dealing with and how you are best likely to tackle. So you can see both the dura and the root completely decompressed, and everything was just done through the axilla of the root. Now this is another scenario where you have a big extruded fragment, so you have disc going from central to the far lateral, and the patient had a complete foot drop on one side. This is how she walked into our OR. So again, you have to plan it a bit differently here. You need to. So what we did is we first approached it through the axilla. So you can see I went through, and because the root which is already compromised, and there is already a big disc lying there, it was not at all mobile. So you went to the axilla, you sort of debulk the disc material. Even a small amount of debulking here will really give you some space before you literally mobilize the root. So when you are going MIS, when you are going endoscopy, the most important thing for me is to plan it right. You really need to it's not about just putting a scope inside, but you really need to plan it. So once we have done a bit of debulking and went through the through the axilla, that is the time we realize that now we should be in a position to mobilize the root. And you can see this is the shoulder of the disc, this is shoulder of the root, and there's a big disc lying here. So once your dura is mobilized and you have enough space for the root, that is the time we went. And you can see we are looking quite up now, because that is where the extruded fragment was causing the foot drop. And then you just go in and you take out the extruded fragment, and you really don't need to grab the whole bite. You can just go one by one and have patience and wait for the big fragment. So this is as you can see, this is quite a big fragment just on the shoulder of the root, and I think this was the main problem which was causing the problem. So that was so, and this is when we look at this the whole fragment which we came out is. So this is how it looks like, and the fragment was so big that it won't even fit in your scope, and you really need to remove the whole of the scope just to get it out. And this is how it is. So the most important, and this is at the end of the discectomy, you can see the dura, you can see the root, and ultimately we went on to remove quite a big fragment. So most of the endoscopy, and this is the post-operative MRI, you can see both the axial and the sagittal cuts showing good decompression. So the endoscopy is more important is to understand what you want to do rather than just putting a scope. The next, of course, when it comes to endoscopy is a transfemoral approach, where as Dr. Abbasi was talking, you go through the Cambrian triangle and you use the natural corridor between your the exiting root and the superior arterial process. So again, there is a difference between interlaminar and transfemoral in the sense that they do have their own advantages, disadvantages. While the transfemoral approach could be a very, very minimally invasive approach, but it has its restriction because it does follow a very fixed path. As you can understand that the facets is what defines your path. So if you are planning to go through a transfemoral approach, you really need to plan it well. And if you want to approach something as central as this, so you really need to take a very, very sharp trajectory, or you need to take a bit of the facet. So just to make you familiar with the transfemoral approach, this was a case of a central disc at a higher level, and I prefer this, and it's a central L2-3 disc, and the patient has bilateral reticulopathy but with weakness, and here we went to a transfemoral approach. So you use the transfemoral corridor, but again you need to target it right. As you know, this was central disc, so we really went through a very, very steep trajectory so that we end up literally where the disc fragment is. So you see we're right in the center of the disc, and this is where the disc fragments we could approach. So this is the big this is the disc fragment which is coming out, just to show you how it looks like when it comes out. And you can see we have used a transfemoral approach, and this is just to go to the last of it. This is the post-operative MRI. So again, both the approaches, they have their advantages and disadvantages, and but you need to understand what to do, when to do, which one to use it, and they do have its challenges. Nothing we do or learn new doesn't come without challenges. So if you see, this is how a microscopic approach or a traditional approach looks like. You have a microscopic vision, you have an assistant here who will help you assess the surgery. Now look at the endoscopic surgery. Look at my assistant. He is not even looking at the screen. Look at the other assistant. He's just simply holding his hand. So one of the most important challenges with endoscopic surgery, it's a one-man job. Of course, you have the team to support you, but you need to do everything. You need to retract the dura. You need to retract the nerve root, and you need to tackle the disc or whatever pathology you're tackling, all by using the flexibility of the scope. Again, it's a very, very mobile system. Whether when you're using open.
Looks like we lost Dr. Sharma somehow, unfortunately.
Yeah, maybe Dr. Yogi, maybe you can text him that we lost the.
Looks like a loss of power or something.
I think maybe loss of power.
Yeah.
So we can start the next speaker, Dr. Varun Agarwal.
Yeah, sorry, I just lost the connection. Can you hear me now?
Okay.
Yes, we can hear you.
Yes, I'll just finish off. I'm sorry for it. I lost the internet in between for whatever reason. Okay. So this is what I was on this slide. So as I was telling, it's a very, very mobile system, like the fixed tubular system, or when you're doing open surgery. You need to tackle that when you are thinking about endoscopic surgery. Again, the epidural bleeding could be a nightmare, because this is how it looks like. If you have bleeding in your field, absolutely, you cannot see anything. And so if you cannot see anything, you cannot do anything about it. So you need to be very, very meticulous to coagulate that, to find the bleeding point and go ahead. Again, it requires some amount of training and technique to be able to tackle it. And so once you can tackle it, that is where you can go ahead with the surgery. Another problem is the neural retraction. As I told you, there is no assistance available for you. So you really need to use the flexibility of your outer sleeve. So this is how we do it. You use the outer sleeve to retract your neural structure out of the way, and so that you can do your surgery safely. So we have retracted that the root, and now I can see the disc fragment, and we can do the surgery. And once you have, again, if you go back, then once you go out, and you can see the flexibility of the neural element, which is again very, very important to understand that you have done a complete job. More than this, it does open new frontiers when it comes to surgery. And I know Varun will talk about it, but just to give you an example, this was a 26-year-old female, and you can see this all osteophyte growing inside, and she had she had significant radiculopathy and weakness. And you can do a fusion, but we really didn't want to do a fusion in 26-year-old female. So this is what we did. So we used the endoscope, and we navigated it, and we could exactly track the osteophyte. We can track the osteophyte, and we went to a transferal approach, and you can see this is how the track that we can exactly track the osteophyte, and we can burr it going through a transferal approach. And in 26 years old, you can avoid a fusion surgery. You are giving her some flexibility for the rest of her life. And this is how we did it. You can integrate the technology, and you can do things which, not for every case we do it, but once in a while, it does bring something to the table. And I know Varun will talk more about it. And it does let you see something which you have never seen before, and some interesting things. You can see this was a endoscopic cervical surgery and discectomy. And you see there is a conjoined nerve root, and it's very, very easy to see it, very, very easy to protect it, and you can still go ahead with the surgery. So it does throw you some surprise. It does allows you to venture into some very, very different things which you have not done before. So, and when it comes to, is it worth it? This is a patient with foot drop, and this is C walking the same day, and almost C recovered by 2 grades following that the case I showed you earlier. And I prefer it specifically when it comes to revision surgery. This was our own case, open laminectomy, and he came with a 2-level re-prolapse. And you can see this is my incision in my own hand 5 years back. This is the incision after a 2-level revision discectomy, and that is what you give them following the endoscopic surgery. And we talk about the complication and everything and the rehabilitation. It does allows you to reduce your complication. It does allows you to have a faster rehabilitation. And one of the reason it does is, if you see this was the case, you can see we have done, there is a small dural tear, and you can see here right now, this is a small dural tear somewhere near the shoulder of the root of the dura, a very, very tiny tear. But you can tackle all that, and you can simply bypass everything, turn your sleeves, protect yourself, and complete your job. And you don't need to bother until it's a big dural tear. You can simply put a flow seal. The reason, and this is on the left-hand side, you can see this is a post-operative MRI. The reason you can get away with that, because the posterior elements are completely intact. And the reason they are intact, because if you see this is after a surgery. This is the only flavum you have taken out. The complete flavum is completely intact. There is hardly any dead space which you have left. And the moment you pull out the outer sleeve, the muscle simply falls back, and it gives you a natural protection against the complication of pseudomyelin or something like that. And this is what we studied and we published in the latest one of our latest paper, and where we saw that not only that if you're using the MIS, the rehabilitation was very, very faster. The complication related to specifically the dural tear was significant less, and even when it came to need to revise this, none of the patient, I think we had more than 420 cases in this series, and none of the patient we needed to revise. And one of the reasons why I think is that your posterior element is completely intact compared to open surgery, where there is a chance, even if you've done a very meticulous job, sometimes there's a chance there could be a releak. So the posterior element really protects you from having that dead space, and that is what it is. So we know the spine surgery, just like mobile phones, are evolving every day, and this is how we have evolved over a period of time. And my take-home message will be minimally invasive spine surgery, especially the endoscopic approach, is one versatile technique which allows a surgeon to tackle a range of pathology from cervical to lumbar spine. MIS allows for faster recovery. It does allows reduced complication, but it does comes at a learning curve and does require some bit more radiation. One should choose what works best in his hand, and this is what I leave you with. Many people have good aim in life, but for some reason they never pull the trigger. So it's not only about having a good aim, but you need to pull that trigger whenever you can. So if you're interested, do venture into endoscopic surgery. Thank you for the opportunity, and sorry for losing the internet connection in between.
Well, fantastic presentation and fantastic pictures. If I may ask you some technical questions. First of all, in your hand, what percentage of your practice, endoscopic practice, is translaminar versus extraforaminal or transforaminal?
So for whatever reason, I know, because I prefer interlaminar, because as I told you, my history, I've gone from being open to tubular to, that ability to see everything, to see the retraction. I think it is more with the interlaminar. So I have almost 80% of my work is interlaminar, and only 20% where I think the transforaminal does really gives a big advantage, like the case I showed you, where we needed to burn the osteophyte, or you are at a very higher level, L2, 3, L1, 2, because the interlaminar per se is too small, and you need to work more on that. That is where I prefer the transforaminal job. So it totally is patient specific for me.
Yeah. And second question is that, do you use a device to fix or hold the endoscope, or do you use just your hand manually? Do you hold the endoscope?
So I use it manually in interlaminar, but I do have a device which fixes the height. So so that once, because again, you really need to hold it, you have to maneuver, and if you fix the height, it becomes a bit too much to do. And there are people who can do it, but I'm more comfortable holding it freely. But I have a device in between which fixes my height, so it reduces one element out of it, so that you can focus more on what you are doing.
Mm-hmm. And my last technical question is that, do you have do you use like a high-speed drill through the microscope? And if you use that, what is the technical difference of using that drill versus like something that we use in a macroscopic surgery like Midas or Stryker or something like that? How is the feeling? How is the stability? What are the difference between that drill versus a regular drill?
So I do use it, and it's very, very important to use it because you cannot do your job completely without having the access to a drill. There are few problems with that drill. It's not as easy as using the normal drill because you have a very, very long lever arm, and they are very fragile because they go through it. So you cannot really manipulate. The other problem, specifically if you're doing it through a transferable approach, the approach is fixed because you're going through a trajectory. So you really need to plan where you want to go, and you need to plan it from very beginning because you want to, for example, the case I showed where we wanted to drill that osteophyte. Now there is a fixed trajectory you are going, so you need to plan it before you start. So you need to have that trajectory in your mind, how you want to approach it. And so it's very, very specific, and it has to be very, very meticulously planned. But it is like using, when it comes to the experience, it is like using any other drill. But it is a very fragile drill. You need to be careful, and you really need to plan it well how you want to use it.
No, I'm asking that question because I've been using the metric system, and I really like as well Dr. Gupta and Dr. Janjua as well comment on that, what they use and so on. When I use an open surgery or when my cervical, I use a regular like Stryker or Midas. But for my macrodiscectomy that I perform through 18 millimeter tube, I use it's what we call stylus, which is much narrower, much smaller profile. I noticed that I have more vibration, and the control becomes, as a surgeon, we get used to it, but controls become much more difficult. Do you feel that there's a step up when you go from that to an endoscopic, that the control and the vibration and so on become more difficult, or are those problems technically solved?
No, I think the new drill which I'm using, which is from Richard Wolf, is a very excellent drill. When it comes to control and the vibration, I don't think that is a problem. It is more to do with the way it is built. It is a very, very fragile drill. So, you tend to break it. And, the angles which you can use and the manipulation which you can do and the speed which you can do with the Metas Rex, all that at least doesn't come with the endoscopic drill because the way it is designed. So these are the problems with the endoscopic drill.
Thank you.
I'd like to ask Dr. Ayush, I'd like to ask one question. In your transforaminal approach, do you use far lateral approach or posterior lateral approach? One. And number two, like in one of your cases of L2, L3 central disc prolapse, your angle was very horizontal. At that level, if you are going that horizontal, there are more chances of breaching the vital structures. So how did you tackle that thing? Because I could see on your X-ray fluoroscopy that this angle was very horizontal.
Yeah, so you really need to plan it. That's what I was talking about. So you start with your drawing board on your MRI. You see what is the safest angle, what is the angle which you can take, okay, and then you go into. So if you're going to take out that central disc L2, 3, you have to go to the trajectory. Now the trajectory is possible or not is a very, very individual thing because your patient could be very thin, very fat, and all those things come to the picture. The best way, there could not be any dictum to it. Best is to individualize, go on the MRI scan, see what is angle you likely to take, draw that, plan it, and then execute it, and that is how it happens.
I'd like to add one more comment regarding the Dr. Abbasi's question about what is the percentage of cases. As I have evolved from open to MIS to endoscopic surgery. So usually those who have started as open MIS, we usually prefer interlaminar around 75 to 80% of cases because we like to see the neural structures. And in transforaminal approach, you rarely see neural structures, but you are almost at the target point. You have to be at the target point. That's it. And another point regarding the drills, I use Richard Wolf. There is not much of vibration in Richard Wolf, but Rex Medix has a lot of vibrations. So only problem is that these are very fragile. These drill bits are very fragile, and if you are not very fragile and long, and there are more chances of breakage at the junction of the those long drill bits. There's a lot of breakage if you do not do it properly. So my trick for that is I usually hold the stem of the bit so that I do not bend it too much.
I see. Do you when you break it, are they easy to retrieve?
No. Yeah, it is easily retrievable. You can easily, because the breakage is not at the distal tip. It is usually proximally. Breakage is usually at.
And the drill bits, are they like open surgery and so on? Do you have like cutting versus diamond and so on?
Yes, we have drill bits with guard. There are cutting drill bits, round drill bits, and diamond. Excellent. Diamond usually I use for hemostasis of the bone area.
Dr. Neeraj has a question. Dr. Neeraj?
Yes, Ayush, I started my transforaminal way back in 2009, and then I abandoned it. Just for one reason, I could not get the reply of one thing. So, you said that, although you did say that you are only doing 20% of your transforaminal, I just wanted to ask one thing. When you do transforaminal, as you said that, initially you do a debulking, right? If you follow those half and half technique, or, inside in out in technique, or out in out technique. So actually you end up creating a large annulotomy in your patients, and traditionally we have been taught that, the larger the annulotomy, larger the chance of re-hernias. Although, I know literature could not prove it, but in my personal experience, I never liked those kind of large annulotomies in transforaminal. So what's your thoughts on that?
Yeah, so I agree with you. So, I'm a bit selective on transforaminal, as I told you. And, I prefer cases where the annulus has not breached, like a contained disc, because you can go debulk it and basically you're not causing that annulotomy at all, because you go through a lateral approach. So if you're not causing the annulotomy at all, because it's contained disc, if I have to venture into the intradural space, I prefer interlaminar. Why not? You can really venture it, you can go up, down, but the transforaminal literally restricts your pathway. You can go around it, then people do go around it, but it is more you have to burst something, you have to take out something. And so that's why my limitation of transforaminal is cases where I think it does have a significant advantage. For whatever reason, I am very, very comfortable with interlaminar, and people say it has a more learning curve and all that. But for me, it was from day one we started with interlaminar, and we stayed with it. And we think it is for someone like you or me or someone like Varun or experience.
Our orientation is much better if you go interlaminar.
Why not to do something which you are already aware of, rather than to go in a different path we have not gone before?
For me, I think abandoning this transforaminal, one reason was this annulotomy. Because I was always afraid, what if my patient comes up with further disc herniation? So thank you, Ayush. Thank you for nice presentation.
Thank you so much.
They use they use fibrin plugs. They use platelet pore plasma plugs in those annulotomies, but they are not.
That's nothing is proven. Nothing is proven that it really helps or not. All these anecdotal evidences.
And there are more chances of we sometimes leave the fragment because we don't have much of play there. So we leave some. Are there and patient complains of pain. That is the
because
main
where I was trained, I have seen that surgeons were having actually the brain suit. They do this transforaminal, they check on MRI, and if there is residual, they again go in transforaminal and remove it. I guess in India we don't have that liberty and luxury to either have it in the machine, or we cannot even tell the patient that okay, we have left residual, we'll do it again.
In private setup, it's very difficult. In private setup.
Well, thank you so much. That was a very interesting presentation and really nice pictures. I think Dr. Agarwal is the next to present.
Yeah, I hope I'm audible. A very good afternoon to all, and big thanks to Dr. Abbasi and Dr. Yogi for having me here. So just let me share my screen. I hope it is visible to everybody.
Yes.
Yeah. So I'm Dr. Varun Agarwal.
and I'm a consultant orthopedic and spine specialist at Bareilly and an associate professor of orthopedics at Rohilkhand Medical College. So when we talk about navigation, these are the usual questions that are asked, that it is too expensive, it will slow me down, I'm doing fine without navigation, I don't want to fix what is not broken in my practice, why should I employ another technique? It is just a marketing ploy and it is good for the new surgeons. So this is how man has evolved, and we should ask, are we ready to evolve as spine surgeons? So in the earliest days, this was what the scenario was like. And now we are using iPhones and touch screens and whatnot. Earlier, we used to use these 2D fluoro to place the screws. Now navigated 3D placement of screws there. There was radiation exposure for each step. Even Dr. Abbasi has shown how much radiation exposure increases in these MIS kind of surgeries. But with navigation, we can substantially reduce this radiation exposure to us and to our staff. I don't wear these lead gowns anymore during the surgery. And it is during the surgery where I can, confirm my hardware placement and things like that. So this is the magnitude of spinal problem. Almost 80% of the population at some point of their life has some form of spinal trouble. And the estimated total cost of medical expenditure in the United States alone is around $85 billion US. And complication rates for these surgeries are increasing, including deaths. So this is how spine surgery has increased over time, and the expenditure over spine-related problems has increased with time. This is what traditional spine surgery look like, with big open wounds and large scars. But as patients, all of the patients wants this, that they want just a small, kind of a band-aid, and they can go home as soon as possible. So why MIS? This is one question. And this is the new definition of minimally invasive spine surgery by the AO Spine MIS Task Force, where they say it is a suite of technology-dependent techniques and procedures that reduces local operative tissue damage and systemic surgical stress, enabling earlier return to function and for better outcomes than traditional techniques. So this is how MIS surgery has been redefined. And as we know, like this chart shows, as the complexity of the surgery increases, the benefit of the MIS surgeries increases. For one single level, let's say a disc surgery, and MIS may not be that beneficial over a traditional open surgery. But as the levels increase, the complexity of the surgery increase, and Dr. Abbasi has shown as number of multiple levels he can fuse in just in a couple of hours. So the benefit of these surgeries, these MIS techniques, increase with the complexity of the problem. So where does navigation work? So although it is a great technology, we should understand what is the scope and what can be done with this. So I'll be presenting few cases. This is a case of Carey spine, which is very prevalent in our part of the country. A 55-year-old female presented, she had been taking anti-tubercular therapy. 1 year after that, she had, after completing, she still came to us with backache. She was neuro intact with severe back pain and bedridden. And there was severe osteoporosis, as you can see from the x-rays itself. You can see these two vertebral bodies are almost destroyed, L2, L3 level. And you can also see on the CT and the MRI how much of destruction is there. And you see here, even the L2, L1 vertebra has been hollowed out. So that was the challenge we faced. So this is how we do it with the O-arm navigation. This is it's like an intraoperative CT scanner which opens up and goes around the patient. And you can take an intraoperative scan. And while the scan is being taken, all of the staff and even us, we move out of the OR so we don't get any radiation. So this is how it closes around the patient, and then an intraoperative scan of the patient is taken. And then this is what we did. We did an anti-psoas MIS approach like we do for OLIF, and this is how the placement of the dilators, and this is how it looks like. And even the instruments are all navigated. The trials, the implants, all of these now come navigation enabled, and we can put these navigation enabled screws also, where we know exactly where we are putting, what trajectory we are taking, what direction we are taking. And this is how it looks like on the screen. And this is what was achieved: an anterior minimally invasive anti-SWAS approach, and corpectomy was done with an expandable cage, and posteriorly percutaneous cement augmented screws were used. These are fenestrated screws, and these are intraoperative scans which show very well placed screws, and cement has been put there. The rod has been guided, and with just these small scars, the surgery was accomplished. So this is another case of a patient, 21-year-old female with spinopelvic dissociation, a C3 type U fracture of the sacrum with fracture of the transverse processes of the L5 vertebra with bladder and bowel involvement and bilateral foot drop. So she presented to us with fat embolism. Once all of this was settled, we took her up for surgery. So this is a CT scan and how it looks like. You can see the fracture and the spinopelvic dissociation and the sacral fracture. And everybody is aware of what kind of complications are there with an open sacral surgery. And we did this case minimally invasive, again, using these navigated drill and these navigated guided screws. So you can see here how the drill with the navigated drill is being used. And you can see how we can, safely obtain this trajectory. You can see here in this last screen. And this is the end result where the percutaneous navigated pedicle iliac transsacral screws were placed and patient was fixed. And you can see, and even the sacrum has been reduced quite well by close techniques. And these are just the small scars, some small stab wounds which were used, and no soft tissue complications was there. And by second post-operative day, patient was out and walking with just these small stab incisions. So this is how I do the endoscopic spine surgery, where we do it under local anesthesia. This is a case of a 45-year-old male with radiating bilateral pain in the lower limbs and severe lumbar canal stenosis with a walking distance of just 25 meters. And SLR on the left is 60 degrees and on the right is 30 degrees. So we do these kind of surgeries under local anesthesia, wherein an endoscope is put under local anesthesia. You can see we are even talking to the patient. Right? And on the table, he tells us how much relief he feels. So this is the main advantage of transforaminal surgeries through the transcambin approach. I feel that you can, patient on the table tells us how much relief is there. And all the surgery is done under local anesthesia, like this, and just a 10 millimeter scar, and sometimes we even don't place a stitch, and the patient is discharged the same day. So this is a truly outpatient kind of a spine surgery. So this is how it looks like under the scope, where you can see the epidural space, the posterior longitudinal ligament, disc space, etc. And this is how the fragment was retrieved under local anesthesia. This is a 2-level case, also done under local anesthesia. So this navigation and endoscopy, these represent the pinnacle of minimally invasive spine surgery. And when we combine these two techniques, so a whole new avenue opens up. So this is a case of occipital cervical anomaly of an 8-year-old male who has been neglected 8 months old at presentation, and he presented to us with complete quadriplegia. So the scan showed an occipito-cervical assimilation, and even C2, C3 is assimilated. There is subluxation and basilar invagination, which you can see quite clearly here. So this is the CT angiogram, which shows that both the vertebral arteries are going over the joint. And so it is very difficult and almost impossible without dissection to put these screws in these vertebrae because of coverage by the vertebral arteries on both the sides. So this is the traditional options in front of us. We can do a transoral orontectomy or a Goel-Harms fixation or even a DCR technique, and some endoscopic options such as endoscopic endonasal orontectomy, etc. have been described. And some tube MIS options have been also described in literature, wherein a tube has been placed transorally. So this is how we approach this case. The patient was placed supine and O-arm navigation was used. And you can see here that the tracker, instrument tracker has been placed on the endoscope. And a retropharyngeal approach was taken by the standard anterior approach and just a stab incision. And you can see here that with the use of navigation, we have been directed towards the odontoid, and we are using the drill and all. So an odontectomy was done. This case was done under GA though, and this is how it looks like. And then in the second stage, he was fixed posteriorly. We choose this method of fixation because of the vertebral arteries there in the screw trajectory. And this is 20-day post-op. You can see how the patient who came to us with complete quadriplegia, and he started recovering quite well. And this case is quite old now. So this is a 2-year follow-up, and you can see that the child has recovered very well. He's now walking, going to school, and doing all the things. So this is the benefit which we can derive by marrying the two techniques and knowing what cases to do. So full endoscopic uniportal odontectomy, all this technique has been described by Dr. Royton in these 3 papers, wherein a retropharyngeal odontectomy for anterior craniocervical infection was done, and we used navigation again just to orient us and give us an extra advantage here so that we don't have to take repeated x-rays. Then this is a case of caries spine. So again, a conservative and radical surgeries. Are there other options for such cases? A surgical middle path, so as to say, as you know, that caries is a very frequent kind of a complaint in our part of the world. So this is a case of a 15-year-old female with caries of D7, D8, complete quadriplegia. She was complete paraplegic with the MRI showing a big paravertebral collection and cord compression at D7 and D8. So this patient was planned for decompression and fixation, but then the COVID second wave struck. This is a case done recently, and this was during the COVID second wave. And you know, there was a severe oxygen crisis in the hospital as of all of India, and we didn't know what to do because we couldn't post this case because of oxygen shortage and patient requiring GA for this. So we decided to proceed under OAM guided 3D navigation under local anesthesia. We put our endoscope with the navigation giving us direction and a safe trajectory. The pus was aspirated and the dura was freed, the cord was freed using the endoscope under local anesthesia. So this is a dilator wing cup. The navigated Jamshedi was used to get the trajectory. Then the guide wire was placed. Then the scope was placed. So this is how it looks like under this navigation. We were safely able to put the scope in this area, and then the cord was decompressed and the patient was discharged on AKT. You can see these X-rays, how the scope is being placed in this area. And then patient presented after 4 months with complete neurological recovery. The patient was on bed rest and anti-tubercular therapy. And then we took it up for second stage when the situation in the hospitals after COVID improved, and an MIS fixation under general anesthesia was done, again using OAM 3D navigation, where just, you can see all these posterior muscles have been left intact and just stab incisions has been used and a transmuscular approach has been used to fix. And this is how it looks like after surgery, and the patient is comfortably walking, and you can see a big surgery like a VCR or decompression, anterior decompression was avoided with these MIS techniques. So when we talk about technology, we can say that we are the early adopters, and we are still learning about these kind of techniques. There is always a debate about what benefit do these bring onto the table, but as your experience with these kind of technology grows, you can apply it for more complicated cases. So when in the 19th century, this was the first spine surgery reported, the mortality was there. The patient did not survive. In the 20th century, we have reduced this morbidity. And in the 21st century, with these minimally invasive techniques, we are talking about what outcomes, how early you can send the patient home, what benefit you can give. So this is how our practice has been changing. And this is the paper which says that image guidance can even assist even the most experienced surgeon. So we should not discount these technologies. And you should ask yourself, when even your cab driver is using GPS, why aren't you? And this enhances quite a lot of patient safety and brings a lot of opportunity to the management. So thanks a lot for a patient hearing. And if there are any questions, I can take them now.
Thanks. Good presentation. Dr. Agarwal, I have a question about the case you presented with the POTS disease. I think that's a really good case. I mean, certainly you have done a lot of other cases too. Good cases, good collection. So essentially, your goal was to drain that paraspinal abscess, and where you essentially, what was your trajectory? I mean, what essentially your point of interest was where? I mean, you ended up in the vertebral body through transpedicular approach, or I don't think you used transpedicular approach. So I was kind of
it's not a transpedicular approach. It's a transforaminal approach, like we do it for the lumbar spine. And with the aid of navigation, you can safely see where is the pleura ending and what is the direct trajectory through the foramen and into the anterior disc space. And from there, since it was liquid pus, we could drain it and just angle the scope and see the bottom of the dura, and anteriorly where the compression was, we were able to, sort of decompress it. So this was quite a, case which I would say serendipitously we were doing, because you see, in the COVID second wave, there was no oxygen in the hospital, and this patient had traveled for almost 200 kilometers with a very poor patient, and I didn't have the heart to send her back with paraplegia. And we had all the consents with all the thing that maybe, this doesn't work. And even I was astonished when after 4 months, she returned to me once the COVID wave was down with a complete neurological recovery. Once the pus was drained and the compression from the anterior sac was, removed. So then we decided just to put in the percutaneous screws and let it heal with the antitubercular therapy. Traditionally, we would have gone for a VCR. In fact, we had planned that kind of a procedure. So
those are very difficult cases, I think.
So sometimes these MIS techniques do throw us surprises, even
that's great. That's great.
That we expect from them.
Very impressive. No, that's very impressive. You need a lot of heart to do it, but I think it's pretty impressive.
Exactly.
You guys did amazing. Yeah, that's good.
So this is the benefit which we feel even the transcambon fixation, like Dr. Abbasi has been showing, we do it under epidural anesthesia and local anesthesia combined. So that is where in our part of the world where neuronavigation is a luxury. So this awake patient is the sort of neuronavigating themselves. They keep telling us. So what we do is we put in the local anesthesia, put in the guide wires, take the feedback from the patient. And what I find out, it is just the placement of the screws and the passage of the rod through the muscles, which is actually very painful for the patient. And that is where we switch over to epidural anesthesia. So we are trying to do these kind of fixations even in awake patients. And I never shy away from staging my surgery. I've had a very good experience in staging.
Oh, that's great. I think staging is perfect. It's the safest way to approach. I think that's very good, especially for complex cases. I absolutely recommend it. That's phenomenal.
Well,
so if the patient is well explained that he would be undergoing a stage surgery, I have not found any patient who has objected yet. And it's the doctor-patient communication.
Fantastic. And pertaining to, to Dr. Abbasi has a question, but I just want to make another comment. The endoscopic transoral odontectomy or endonasal odontectomies we did at Cornell, and I was not part of those publications, but certainly we did probably 6 or 7 cases during my training. I think it's you require a lot of heart to do it, but I think it adds substantial help to the ventral, cervicomedullary junction compression, like the ventral compression, and especially with what Dr. Goel talks about, the subluxation of C1, C2 joints and leading to the retroversion of the odontoid and ventral compression of the cervicomedullary junction and so forth. I think there's a role. Absolutely. You have to find the right patient. And so how many cases you guys have done like that? The I'm sorry, I forgot the track. Was it endonasal or transoral you did?
No, it was not endonasal or transoral. So see, those kind of surgeries have their own set of complications, and you need to go through that oral and nasal flora with the infection kind of a thing. So we went through the neck only. So it was the same approach which we use for the cervical discs, but because of the angulation and the mobility scope and the guidance from the navigation, that you are able to reach the C1 at an angle, and using the drills and burrs you can just shave off the odontoid. So it is quite doable, and you just bypass all those kind of complications which are there with an endonasal or
interesting. Wow. Okay,
that kind of a surgery. So that is where navigation kind of helps in orienting you again and again that you are on the right spot.
Yeah. The question I had for you is that obviously in the United States we don't see as many TB in the spine as probably you. What do you think? I haven't done any TB in the spine, and I don't know many people who have done many. What do you think in a regular spine practice in a university? What's the volume of the spine TB or infection-related spine cases? Because I think medicine and surgery is experience by doing. Probably you are more an expert in that than a regular university here in the United States. What is your volume?
So in our part of the world, I think a major chunk of any spine practice is formed by tuberculosis. And I think around 30 to 40% easily could be, for any practice could be set aside for just tuberculosis and other infection kind of cases. Then comes trauma and now degenerative as the life expectancy is increasing and we are catching up with the Western civilization with, in terms of lifestyle and all. So all that is increasing.
I think we should ship all our tuberculosis to you. Because, this is like...
So with these kind of approaches, actually my entire, handling of these kind of cases has changed dramatically. We just put in the scope in the disc space, transforaminally under local anesthesia, just do a debridement of that area and, just put in percutaneous screws. You may put in the percutaneous screws, you may not, depending upon the case, but a thorough debridement with an endoscope with a, irrigation, water irrigation channel, that substantially decreases the pressure the pus has on the periosteum and all that, and decreases the pain substantially for the patient. And as well, you get a biopsy material for your diagnosis.
No, I think as well, regarding the management of these cases, is not only about the technical. I think what you get with your volume as well, the experience about the total management from diagnosis to post-op care and so on. And that is truly, I think, in the United States we are lacking. So thank you. That was very interesting. So Dr. Janjua, I think I'm being told that it's your turn now.
I know, but it's getting late here, you're right? So
not for a neurosurgeon. For a neurosurgeon, this is not late at all. So,
I know. I just don't want to, wait long for me.
I'm excited to hear your presentation. So please go ahead.
Thank you so much. No, I kind of a little bit. We're going to change gears a little bit. I mean, it's not truly MIS, and I kept thinking, this was a kind of a talk at the very last minute I had, so I thought probably just to share that and sort of see what we're talking about. Let me just try to make sure that I do the sharing. And okay, so sharing. Okay, can you see, please?
We see it.
Okay, fantastic. So I'm just going to go fast. I think it's pretty late here, but I know everyone up there in India is probably mid-morning or something early afternoon. So essentially just going to talk about a little bit about vascular malformations. I think when we talk about, start hearing a lot about, degenerative spine, and we come across, most of the patients, I think I just sometimes feel like we just do not want to forget as a neurosurgeon that some of these presentations can be catastrophic if we really don't know what exactly is going on. So I'm just going to talk quickly about the outline, the introduction incidence of vascular lesions. My focus is purely going to be spinal cord arteriovenous malformations. I'm going to revisit the vascular and arterial and venous anatomy of the spinal cord. Talk about the classification schemes out there, certainly, and some types of spinal cord malformations. A brief discussion of the demographics and imaging findings of each of different types and considerations in terms of the management and role of angiography and embolization in these management of these lesions. And at the very end, it's going to be a quick conclusion. I have a lot of slides, so please excuse me. I'm just going to skim through fast. Spinal cord malformation, as we know, are comprised of a significant number of spinal problems. Incidence is quite high in patients between age of 20 to 60. Some cases have been misinterpreted as a degenerative spine or spinal stenosis. Certainly, vascular anatomy of the spinal cord is important. We know there's anterior spinal artery, so midline, anterior vessel, and two posterolateral, which is in the back is the posterior spinal artery. And each level has a different contribution from cervical to the lumbar levels in terms of the arterial supply to supplement the anterior and posterior spinal artery for a robust spinal blood supply to the spinal cord. However, between the T4 to T9 level, interestingly, the spinal cord has a very tenuous blood supply, and we need to stay cognizant of that when we are trying to operate on different patients in terms of the different spinal deformity corrections and or high-level sharp grade 3 or 4 and above osteotomies. So certainly, we look at the segmental levels. Each level has a blood supply to the nerve root and the dura. And blood supplies primarily comes from reticulomedullary artery, which is from which contribute to anterior spinal artery, and reticulopial artery, which is essentially more towards the P of the spinal cord and contributes to the posterior spinal artery. So anterior spinal artery, as we talked about, reticulomedullary arteries contribute. Primarily important thing is to keep an eye on the artery of Adamkiewicz, which is typically in about 85 to 75 to 85% of cases from T7 to L1 on the left side, predominantly in about 77% of cases. Different contributions, as we talked about, vertebral artery, ascending, cervical, deep cervical, thoracic, and lumbar segmental arteries, median sacral, fifth lumbar arteries, and lateral sacral arteries are also contributions. 10 to 20 about reticulopial arteries, as I talked about. I'll show you a little bit more in the subsequent photographic representations and cartoonic representations. So this essentially pretty much we can see there is aorta. It has its branches from the subclavian artery into the ascending cervical, thyrocervical trunk, and so forth. It is supplying primarily in the cervical region, and then posterior intercostal arteries are primarily robust blood supply to the thoracic and thoracolumbar region, and then subsequently the lumbar vessels and which are primarily the radicular lumbosacral arteries, and then the median sacral and lateral sacral arteries subsequently in the levels below. So just a little bit more, again, diagrammatic representation. As you can see in the dural sleeve, we can see the artery. It divides into the dorsal or ventral ramus, or I'll talk more a little bit in detail, anterior posterior spinal arteries, and they contribute to the anterior spinal artery or the posterior spinal artery, respectively. Another better view, we can certainly see aorta has its posterior intercostal artery, which divides into the spinal branch, which furthermore divides into a reticulomedullary artery or the anterior spinal artery. Posterior spinal is the reticulopial artery, which contributes to the posterior spinal artery in terms of the robust blood supply. Again, segmental vessels at T5, T7, T10 and L2 levels in terms of the artery of Adamkiewicz variations, but typically we just do not want to forget T7 to typically L2 or T9 to T12 sometimes, but generally T7 to L2 more consensus is about the higher proportion of this blood vessel to avoid any spinal cord infarction during our advanced level of deformity correction surgeries. Certainly there are other nutrient branches to the bones or the vertebrae for robust blood supply to the superior and the inferior and the posterior central arteries branches to the bone itself. So venous drainage is very interesting that the venous drainage of the spine is anterior and posterior spinal and radicular veins. And interestingly, the veins in the spinal cords are valveless. And so forth is the epidural venous plexus or Parsons is also valveless. And primarily it is extradural venous plexus, extravertebral as well. And there are certain veins to the bony nutrient foramens of the vertebrae. So just a quick view. I think this, for me, it's a good understanding. We look at the anterior internal venous plexus, which is inside around the dura, epidural, but inside the bony canal. Outside is the posterior external venous plexus, and on the sides, paravertebral are the ascending lumbar veins or lumbar segmental vein at each level contribution in front of the transverse process. This is how the Batson plexus forms essentially. As we know, anterior and posteriorly, we're looking at the anterior internal venous plexus, which is extradural and more so primarily ventral to the thecal sac. And different watershed areas kind of very important for us to know: cervicothoracic region, mid-thoracic, and thoracolumbar region. Got to be careful at these areas. Essentially, when we're talking about the intradural work for spinal cord tumors, dissections, these areas should be considered even for the embolization or angiography techniques, that these are the watershed areas. Classification, now I'm going to come back to the topic word, essentially. Primarily, first of all, as we know, Dr. Yassergul come up with this classification in 1969 based on topography and pathophysiology and anatomic location to the dura and spinal cord. And subsequently, really, guidelines have been set forth by Dr. Spetzler from BNI in 1992 and in 2002, and talking about the spinal cord AV malformation classification. This is the classification which was devised in 1992, and still, for me and for everyone, pretty much is the classification to remember, to look at, even for the examination purposes and as well as in your clinical practice. For type 1 are the more common ones: spinal dural AV fistula. I'm going to talk more about them. Intradural, intramedullary. Essentially, we call them most commonly with glomus type is the spinal cord AV malformation type 2. Type 3 is the juvenile type, which is metameric, meaning it involves the whole segment. Some of the syndromes are associated with it, primarily more commonly with Cobb syndrome, and they are associated with the scoliosis. That's how the Cobb name also comes in. Type 4 is the intradural perimedullary AV fistulas. They're primarily more ventral than dorsal, and that's how they are distinguished, and they're more peeled in character as compared to the type 1. I'm not talking about paraspinal epidural fistulas or cavernous malformations or any isolated aneurysms here. So Spetzler's come up with a new classification in 2002. He categorized them into a neoplastic, aneurysms, and then AV fistulas, and then AV malformations, essentially. So pretty much we're going to discuss more here about AV fistulas and malformations. We're not going to talk about the aneurysms or the neoplastic categories. So old versus new classification, I think primarily just to think about, for me, when I look at and try to comprehend, type 1 is spinal dural AV fistula, which is dorsal intradural AV fistula, and more amenable to surgery. Type 2 is glomus arteriovenous malformation, which is intradural, inside the substance of the spinal cord AVM. Type 3 is, which is a type of and it is juvenile type of AVM, extradural, intradural, comprising both, involving the whole segment. Type 4 is the perimedullary, which is ventral intradural AV fistula. So I think this slide is really helpful in terms of the first classification helps us to know exactly what are the broad category is, and then the second classification on the right side tells us really, is it dorsal fistula or ventral? Ventral is going to be type 4, dorsal is going to be type 1, and if it's inside the substance spinal cord, remember it's going to be type 2, and if it involves the inside the spinal cord, meaning intradural and outside the spinal cord, at that particular level, we will call it junctional, because it's going to involve the vertebral body as well.
So complications, certainly arterial steal. We commonly see venous congestion and neurological symptoms associated with it, or hypertension, and then spinal cord ischemia are the real presentations. So type 1, primarily 80% etiology, we talked about it, mostly it's unknown, and some rare cases, trauma or venous obstruction can be associated with it. I'm not sure if it's really etiology, but interdural fistulas, primarily they exist on the dural nerve sleeve. They're low flow, and they have retrograde venous congestion and hypertension or compression at that level. There are two types, could be single or multiple, as the diagram, the cartoonic representation is pretty obvious at each different sleeve levels. The cartoonic representation, more just to tell this is a normal anatomy, looking at the aorta on the front, posterior intercostal arteries, and then they're giving the spinal artery at each dural sleeve level. And this is how venous engorgement develops over time when there is a retrograde flow into the venous structures or the PL veins. So in general, most commonly type 1 is seen in males 40 to 60. Progressively, these patients present over months and years. They can present literally with the similar degenerative kind of symptoms. They can have back pain, but more so common radicular symptoms are more common. And then certainly when they can develop advancing neurological levels, then it becomes really a big concern. Worsens with the increase in the intra-abdominal pressure. It's just kind of a test. I don't know if we typically do that. We usually forget this or ask patients about this. But typically, worst form is the subacute necrotic myelopathy, which is more so historic, but can present, which is a flaccid paralysis, ascending sensory level, and with the loss of sphincter control. Name to it, Bios-Jonin syndrome. So in terms of imaging features, we look at it, T2 hyperintensity, which is typically central, low thoracic to conus. It can be at any level. It can have typically more commonly, we also see a serpiginous perimedullary veins, which are very engorged veins, and they are usually very helpful to see on sagittal T2 images. Then definitely cord swelling has been observed, and in rare cases, we see patchy or diffuse enhancement on the gadolinium, and then certainly on if we do CT myelogram, which Dr. Abbasi does in his regular practice, it's a phenomenal test, and we see serpiginous filling defects because of those engorged veins sitting in the dorsally. So in general, we need to essentially determine the level of shunt, which we can use MRA. Certain cases have been reported. It's just a picture that been operated considering the disc bulges, and people have gone up to putting cages and things like that. So certainly be cautious of that. Trying to do every best possible test that we can do so that we do not overlook these cases if they present with a questionable or red flag neurological symptoms which are not concordant with the imaging. And I think that's the biggest, the real nutshell of the talk. So looking at dural AV fistula, so we can see it primarily. There is a lot of advanced degenerative disease, but however, we are seeing something very unusual, which is T2 hyperintensity in the substance of the spinal cord and some serpiginous presence of the blood vasculature, or on which is quite concerning, more ventrally and dorsally, and then more so prominent, and which is outside of the presentation, how patients present. This is again type 1. We will see those serpiginal vessels, as we talked about T2. Sagittal sequence is helpful to really look at and identify those blobs of blood vessels, which are essentially PL veins, which have been engorged as a result of the fistula. Another time result MRA, as we talked about, just to identify the level where, and certainly we see in the dural sleeve engorged blood draining veins can be seen in the middle view. So angiography, certainly very helpful in these cases. Mandatory we can identify single multiple feeders, and essentially primarily the shunting is most commonly is seen on the medial aspect of the intervertebral foramen, and that's kind of comes with Dr. Lawton's most of the techniques and That's what he talks about. And the draining vein essentially fills these tortuous medullary venous system. Again, for understanding, when we look at the in these dilated structures, always the PL veins, and the tortuosity is the more tortuous and small caliber at the artery, and then we see the connection at the dural sleeve, which is primarily the root cause, which is a fistula, but the culprit is the draining vein. Again, different views for multiple feeders, and then we can talk about how these cases have been mistreated in the past, and unfortunately can happen with anyone with just primarily thinking about simple laminectomy or thinking about this is something merely a spinal stenosis. So in differential diagnosis, we need to consider, especially in the higher levels, as we know, multiple sclerosis, and in the absence of brain at T2 images or T2 sequences, in absence of brain findings, we need to nail down on neuromyelitis optica, which is primarily Davick's disease. And then we should not forget about transverse myelitis, tumor or traumas, or any other types of vascular malformations, which is common. Infarction was a catastrophic presentation, just for a slide to see and remember how it can present. And so in terms of the treatment, proximal portion of the feeding artery is not really adequate, so must occlude the proximal portion of the draining vein. That's where the culprit exists. And if you do that, certainly you achieve the control. Can be done with the embolization techniques. And make sure when we do the embolization, we just gonna make sure we talk with our colleagues not to look at the radiculomedullary artery, because as we talked about, it's going to be a contribution to the anterior spinal artery, and especially if you're close to the T7, T9, L1 levels, it's going to be really a catastrophic presentation. So we must divide the draining vein at the dural sleeve, and some pictures intraoperatively during the time, and as we can see here, there is a draining vein which is leading to the serpiginous big draining blood vessel and the dorsal aspect of the spinal cord after the durotomy, and that's what we're going to tackle. So we will identify that particular place with the arachnoid overlaying the draining vein, and then subsequently we will embolize that draining vein at the dural sleeve, and we will dissect and we will cut that draining vein, and we will run an ICG, and we'll see that it is draining initially, but in the subsequent run, you'll see, there is no connection, but it's a runoff into the serpiginous blood vessel, which is kind of becoming more prominent in the later runoffs of the ICG. So in terms of the, spinal AVMs versus dural AV fistula, how to kind of think about it and divide them. So primarily, more common are the dural fistulas. They're about 80%, and they are low flow as compared to the rest of the type 2 and type 3 and type 4 ones. And they are mostly presenting sometimes with the venous compression symptoms, or even with the ascending myelopathy, and or sometimes rarely with the hemorrhage. Mostly patients are older than age of 40, and usually the levels are in upper thoracic to mid thoracic to lumbar level. So T4 to L3 primarily more common presentations. So now jump on to type 2. I'm taking a lot of time, and it's just glomus intramedullary. Just wanted to show it's more so inside the substance of the spinal cord, and it primarily presents more commonly in younger adults. Progressive myelopathy because of the steel, and very cumbersome to operate and deal with these AVMs if they are bigger in size, or sometimes if there is no well-defined a dissection zone between the tuft of blood vessels and the spinal cord substance itself. Mortality is not that high, but the paralysis of morbidity is quite high, and hemorrhage can happen in subsequently in the first years. So that's how they look like on the T2 sagittal sequence. And then again, a representation how radiculomedullary artery, as we can see, is primarily the culprit. Diagnosis, we talked about it. It's going to be very spinginess blood flow voids on the T2 or as well as on the CT myelogram. And then, unfortunately, especially on CT myelogram, we do not really see the cord itself. So cord essentially pretty much wipes out because of the arterial steal and the presence of these big enhancing blood vessels. MRA, we will see it's again these flow voids, and sometimes the cord can be swollen. So or sometimes we see a cord being very getting ischemic, or can be in early phases edematous. Primarily, just a few things to look at. Again, we need to rule out sometimes can be confused. Remember with the tumors, which are primarily intramedullary tumors, based on the age, early patient, young patients, especially gender, females could be astrocytomas, but mostly in older elderly people, it can be hemangioblastomas or ependymomas. But make sure, sometimes these AVMs can present and appear like tumors on different sequences. Essentially, that's how when we do multiple sequences, we look at it, we can nail that this is something different. And then MRA and then time resolved MRA essentially helps in trying to further delineate them. And in geography, certainly is the gold standard. Look at single or multiple feeders, and multiple feeder is going to be more robust, as we can see on the right side. Also, make sure we do not forget the intranidal aneurysms in these cases. So, essentially, type 3 is the juvenile type. We talked about this is primarily very worst type. It's intradural and extradural. I have not come across any of this case, but just to remember, these cases. I come across one type of this case, but that was a upper cervical level, and essentially there wasn't any treatment. We were just relying on embolization to tackle those cases primarily. But this is a segmental. It is also called as metameric, or because it's intra and extradural both inside the vertebral body as well. These are really not a surgical candidate, and as we know, pretty much all will know, and they can have bony anomalies or scoliosis. So that's how kind of the presentation can be, just for understanding, and that's how rare images we can find where how they're gonna ugly and really hypervascular they're gonna look like. So type 4 is the perimedullary. It is relatively common, and it is more ventral, and there is a congenital association with these dural AV fistulas. They're going to be more ventral, and they're going to have abnormal nidus of the fistulous communication between the arteries and the ectatic spinal veins. They are demographically more common in the younger population. No gender preference, but as we discussed, they can have association with the different syndromes, which is Prox-Weber and hereditary hemorrhagic telangiectasias, cavernous malformations, and a Cobb syndrome. That's how they're going to be look like. They're going to be more ventral, as we talked about, and just behind the posterior aspect of the vertebral body. And again, representation. And if we talk about how these they present, we talked about it. Embolization first. Surgery only if they are dorsal. Certainly, we already know you can't go ventral to this cord substance itself. So cumbersome treatment options here. The classification system is pretty much set forth by Dr. Merlens, and that's kind of what it is, which is based on single, multiple, or a joint feeder. So type 1 and type 2 and type 3 respectively. Type 3 is going to be a single joint feeder, very difficult to treat. New classification systems are coming up, but they pretty much overlap on one on top of the other. So that's kind of another cartonic representation. That's how they're going to look like. Again, very robust, very PL. The purple is the PL veins, and how they're going to be more ventral. On the T2 sagittal sequences, we'll see again tufts of blood vessels, and they're going to be more ventrally located in front of the chorda equina, essentially, or the caudal aspect of the spinal cord. If they are dorsal, then essentially the options can be surgical, and you can identify again the fistulous connection and the early draining vein after the angiography, and sort of take care of that. This is similar kind of case, I think it was overlap of type 2 and type 3 I come across during the last fellowship, and it was very difficult to treat. And so perimedullary ventral, we talked about it. That's how it's going to look like mostly on the angiographies. So in general, in just to summarize, just a quick data, which is not very robust, but kind of still pretty gold mine and gold standard. Looking Yasser Gul's primarily 84 study for 41 patients. He was the only one who did a lot of these tumors, and 60% pretty much completely removed, and 40% essentially pretty much stabilized with subtotal resections. Subsequent studies come up with Dr. Connolly, 90, 98, 94% initial angiography cure. And if you look at pretty much about 50% of these patients were treated as a subtotal management, or primarily remained stable. And a lot of these patients ended up having chronic pain syndromes, which is CPRS type 1 type of picture, where they had chronic regional pain syndrome categories, symptomatic regional pain syndromes. And then so type 4, about one of the study, 90% were improved or remained stable. So I think more or less we're looking at very cumbersome to treat if only the good treatment options are really, really in the type 1 category. And operate on pretty much, we can handle the dorsal located Maryland type 1 and type 2, and primarily type 3, which is a joint, type 4 subcategorized joint type of connection, primarily just with the embolization. So in general, endoscopic treatment options are there, as we talked about, for type 4, subtype 3, which is a fistulous joint connection, or primarily type 2 and type 3 categories of spinal cord AV malformations. And curative about type 4, 67% with the angiography, both macro and micro fistulas. Palliative, just to remain stable, type 2 and type 3 are also treated more so with the endovascular treatment to target the hemorrhagic element or the fistulous connection. And during any procedure, certainly MEPs or motor stimulation is helpful. Trying to look at any kind of, or furthermore, we can do D waves just to make sure we are more sensitive and not missing the spinal cord ischemia. So, in general, I mean, I think I'm just going to cut short. Primarily, extradural AV fistulas are more, we're not much worried from them, because if we are not around the artery remquist, and we know that we're not going to jeopardize the blood supply of the spinal cord, and different syndromic associations, primarily again tackled with the angiography more so, and their presentations are typically different than the spinal cord itself, AV fistulas or the AVMs. Some presentations could be Brui, which is, I don't think we typically do that during these days, but really radiculopathy and myelopathy are the concerning things in these patients not to forget and ignore. So treatment options, we talked, in the extradural mainly, primarily just to embolization to rely a lot, and very rarely surgery is the option in these cases, only if the embolization was really successful, and we know where exactly the fistulous connection is, and we can take that down extradurally and call it a day. So in conclusions, non-invasive imaging can make a diagnosis, but angiography really is helpful and dictates the treatment option in these patients. MRI typically does not have a high resolution to answer all the questions that we typically need. So we need angiography and different protocols in terms of really nail down the connections and to treat them. So always consider preoperative embolization for these patients, for finding a safe preoperative options in these patients, or we might negate the need for surgery. Surgery has a big role in type 1, as we discussed, and can be considered in type 2. or in type 4 subtypes, type 1 and type 2, provided they are dorsally located. I just would say thank you very much for everyone's attention. I'm sorry, it was a very, very different, dry topic, and please excuse me for that, a little bit different from MIS, but my focus is kind of a little bit, not only I'm learning a lot about MIS, but I still kind of developed into heavy neurosurgery topics and stuff like that, and come across these cases and try to help my colleagues and do those cases. But if anyone has any question, I'll be happy to answer. I know it's a very dry and different topic, and but just to kind of revisit what we were being told in our residency and fellowships, and just to make sure we're not getting off grid in terms of the really missing important red flags, which can happen, God forbid, at any time during our practice.
What a fantastic refresher, Dr. Janjua. And it's a heavy subject, and you presented it very well. Now, every spine surgeon eventually will meet some myelopathic patient that the reason for myelopathy is going to be what you just presented. So it is, I think, any busy surgeon should include what you just described in the differential diagnosis, to just make sure that we are not missing this kind of picture with a degenerative kind of spine, that there is a little bit of a stenosis, because you can have this and a stenosis, and then all of a sudden all your criteria are based on the stenosis, and you just cannot connect the dot and so on. What do you think, what should be the best kind of, from the start, if we include it in our diagnostic, what study would give us the best bang for buck to differentiate between a degenerative stenotic related myelopathy versus what you just described, a vascular picture?
Yeah, thanks for a great question. I think in my early on learning and practice, what I typically do, if the picture, as you already explained, you just exactly said the same thing. If you feel like the picture is not fitting, then I think the best thing is there's no harm, there's no shame of asking help from your neurointerventional colleagues. But in terms of the imaging, I really heavily rely on MRI, certainly different sequences, and I have very low threshold to order MRA on those patients right away if I feel like there is something a little bit off, which is not fitting in the picture, and then calling my neuroradiology colleague and kind of asking them that the picture is not fitting, and are there better sequences that we can obtain or get more detailed sequences just to make sure we're not forgetting. So I think GRE, as you already discussed, and I think the and T2 are different cube sequences of sagittal and good axial with thin cuts. I think really helps to not to miss those red flags which is coming in the brain. I think absolutely. I think it's just there are patients when we come across we all come across those patients somehow and the other, and their presentation is just a little off. And I know you've been embarking more, which is a little bit off from this SI joint, and I really like that very few neurosurgeons understand the SI joint pathology, and cannot really delineate that from the lumbosacral pathology, and that's where a lot of people just don't sometimes feel like, this does not even exist, and I absolutely can understand. Your practice is really very helpful, and is exactly same thing I'm following. There are certain subset of patients, the really picture does not fit in, and the pathology is somewhere else, and they are being unfortunately treated for something else. And so I think it's just answer to, I think since spine just, heavily on MRI and MRA, and any question, anything concern comes up, I think there's no harm or no shame of asking your interventional colleague just to consider those patients maybe for a quick run of angiography. And if I did that for one girl, and I could not really nail down. Her pictures were not fitting in. She would always come in with a back pain, and the MRI looks good, CT looks good, X-rays looks good, but she was I think she had a little bit of a genetic abnormality, but not syndromic though. There wasn't any syndrome, and I felt like I did this MRI and had a T2 fluoids, and I was like, oh my God, we should do the I called him right away and we did the angiography, but it was very interesting. He said in the angiography, and he showed me that he wasn't able to identify any. There were definitely tortuous vessels, but we could not find any AV fistula, and certainly it wasn't any intermedullary or more ventral. So we could not really categorize it to what exactly it is. But so that was one case that I really recently saw in about a year and a half in the last years of practice, and I could not really understand what exactly it was.
So I'm hearing that the MRA is the best kind of initial investigation for this, and practically if the picture doesn't fit, then to get an MRA angiogram, which I believe any place these days they have MRI machine. If they can get an MRI, they should be able. There is no additional technology needed for that. It's just the setup in the machine itself that enable you to get MRA. But obviously, you need to have the proper neuroradiologist and the expertise to read that, because I think reading those is beyond the usual practice of a spine surgeon. But so get the help. Well, is there any question additionally for Dr. Janjua? Then I would say we come to Dr. Marathe, correct?
Yeah, that's right.
Please go ahead. Thank you for your presentation, and thank you for your patient.
No problem. I'll share my screen now.
Yes, please.
Can you see my screen?
Yes. Mm-hmm.
So, good evening to all the people on the western side of the hemisphere. It's afternoon in India. At the outset, I would like to thank the organizers for giving me this opportunity to present along with some of the stalwarts in MIS surgery. Given that I'm just starting off with my MIS journey, the topic is learning curve and limitations, because that is something which I'm facing on a daily basis. So what exactly is learning curve? The concept of a learning curve was originally introduced in aircraft manufacturing. That is where the term first came into play. Coming to learning curve in medicine, dates back to the British Royal Infirmary Inquiry after increased mortality in pediatric cardiac surgery. So the audit that was carried out after that concluded that with increased operator experience, there is an improved outcome from interventional procedures. So a learning curve can be defined as the time taken by a surgeon to become proficient in a particular procedure so that he is able to perform it independently and with reasonable outcomes. There are many factors that influence this learning curve, which include some surgeon-related factors, some factors related to his training, progressive surgical procedures, and the hospital environment. With regards to the surgeon, his knowledge of anatomy, 3D understanding, manual dexterity plays a role. Progressive training that is structured, wherein there is cadaver courses, operating under supervision, and then graduating to independent surgeries. With regards to procedures, we can start off with injections, then you move on to decompression procedures, and finally you adapt to the fusion surgeries. This all is possible when there is a favorable environment in the OR, which includes appropriate equipment and a trained team for support. There are certain challenges in MIS which makes the learning curve quite shallow. In a shallow learning curve, there are a greater number of repetitions that are required before a surgeon becomes proficient. Some of the reasons why this particular learning curve is shallow includes a limited visualization, a narrow surgical corridor, and lack of clear anatomic landmarks. So MIS can be compared to this classic story in literature where a group of blind men were asked to describe an elephant, and depending on what part of the elephant they came in contact with, they described it as a rope or a spear. So MIS is something like this, where the narrow surgical corridor and lack of anatomic landmarks makes the learning curve difficult. So I went through literature and tried to assess what is the described learning curve for MIS procedures, dividing them broadly into decompression surgeries and fusion surgeries. So with regards to decompression surgeries, Nomura et al. Analyzed microscopic discectomies, and they showed that the learning curve reached a plateau after the 30th case. Endoscopy, Wang et al. Showed that the learning curve was approximately 8 cases, whereas for transforaminal endoscopy, the learning curve described is as much as 72 cases. One of the important take-home messages from Nomura's study was perioperative complications can occur at any time. So even beyond mastering of surgical technique, we have to be vigilant because these complications can occur even at the hands of masters. That takes me back to one case in my fellowship year, which was a straightforward and microscopic discectomy. And my mentor has an experience of at least 2 to 3 decades. But we had a nerve root injury intraoperatively, which was entirely unplanned, and it was essentially a routine case. But this sort of reiterates that these complications in MIS can occur at any point of time, and we always have to be cautious. With regards to fusion, Silva et al. Assessed MIS TLIF, and they showed that by case number 39, there is the learning curve is mastered, whereas Lee et al. While assessing MIS TLIF showed that the learning curve is approximately 44 cases. Lee again agrees with the findings of Nomura, where they found that the rate of adverse events was comparable in both the groups. So that, again, to sort of say, complications in MIS can occur at any point, even beyond mastering the learning curve. For lateral interbody fusion, Chong et al. Described it as around 22 cases, and Vishal Sarvai in his learning curve series for MIS adolescent idiopathic scoli said that the improvement was evident after 20 cases. So if we summarize the available literature, approximately 20 to 40 cases is the norm that is described, except for transforaminal discectomy endoscopy, wherein the number was around 72 cases. Apart from the learning curve, one needs to understand that that may also be associated with certain complications. There was a good systematic review by Cho Kim in Journal of Clinical Orthopaedics and Related Research, wherein they showed that the most common learning curve complication for decompression surgeries was durotomy, and for fusion, it was implant malposition, risk of neural injuries, and non-union. So some of these complications may be such that you may even require conversion to an open procedure, whereas with regards to durotomy, fortunately, in many of the MIS procedures, because of lack of dead space, you can get away without formally stitching the dura together. Following the learning curve, I'll make a segue to contraindications and limitations of MIS surgery. So we all know and understand that minimally invasive spine surgery is here to stay, and it has sort of brought about a paradigm shift in the way spine surgery is pursued. But having said that, MIS is not the answer for everything, and there are certain contraindications and limitations that have been described in literature. So simple PubMed search with the keywords contraindications or limitations yields approximately 953 results. We have to understand that many of these potential contraindications and limitations that have been described in literature have been challenged by many of the pioneers who are even with us today, and they are actually extended indications for them. But for beginner surgeons at the initial learning curve of MIS, it is rather recommended to stick to the classic cases and not delve into the expanded indications to avoid complications. So I went through some of these articles from PubMed and have a summary of few of the important ones. So this was one article by Gun Choi, one of the pioneers of endoscopic spine from Korea, and he describes some of the contraindications for endoscopic spine to be extensive disc calcification, L5S1 level, spondylolisthesis, cauda equina syndrome, and high-grade stenosis, etc. Now, some of these have already been challenged, like for the L5S1, we can always approach it interlaminar, or there's also a description of the transiliac approach that is used. For cauda equina or high-grade stenosis, you can always combine it with an intraoperative epidurogram, as described by Dr. Luke Kim, wherein they used epidurogram to assess adequacy of decompression intraoperatively whenever a high degree of stenosis was tackled by endoscopic approaches. However, for beginner surgeons, it is recommended to stick to the classic indications of endoscopy only in order to avoid complications. For lateral minimally invasive fusion, degenerative listhesis grade 2 or greater has been classified as a contraindication. But again, we saw a case by Dr. Abbasi himself in today's forum where he did a challenging L5S1 listhesis. So, but for a beginner surgeon, this is a contraindication as in literature. Then the Preop anatomy of the, you can see a Mickey Mouse configuration of the vessel, and the normal corridor that is available for oblique interbody fusion is not available. This type of psoas configuration has been associated with greater risk of neural injuries to the lungs and a higher risk of psoas dysfunction postoperatively, and is a potential limitation for oblique interbody fusion. Then the presence of a conjoint nerve root bilaterally is a contraindication for minimally invasive TLIF surgery. So these were some of the summary of the articles that spoke about limitations and potential contraindications for MIS. So MIS techniques involve a highly specialized set of skills which take time to acquire, and their learning curves have been incompletely described, but they are real and important. The other issue is most of these techniques rely on frequent use of fluoroscopic and intraop CT-based imaging with radiation concerns for surgeons and patients. Like Dr. Agarwal described, some of this is already changing. Like in his case, they have OM exposure followed by navigation, which takes radiation out of the equation. But particularly in many of the resource-poor settings, we are still reliant on CAM because of non-availability of OM navigation, and that also remains a concern. So these learning curves and limitations are here to stay. And to challenge these limitations, there is an interesting paper in Global Spine Journal which describes the 6 T's of MIS. So the 6 T's include the 6 key elements, that is a target, technology, technique, training, testing, and talent. And using these 6 T's, we can sort of challenge these limitations and master the learning curve. So the first T is target. This slide was already shown by Dr. Agarwal, wherein he discussed that the benefit zone of MIS lies in the mid zone of complexity. So choosing an appropriate surgery for a patient with a correct pathology that offers maximum benefits is important. For surgeons at the beginning of the learning curve, sticking to the classical indications and not delving into the expanded indications is recommended. The second T is technology. There is a well-described saying which says a bad workman blames his tools, but that doesn't hold true in MIS, wherein even a good workman may not be able to have good functional outcomes without the aid of technology. So in MIS, having your bayoneted instruments, a tubular retractor system, and a good quality burr is something that is essential. Again, magnification and illumination play a key role. This is one of my mentors, Dr. Ayush Sharma, with his favorite microscope, doing minimally invasive procedures. And I'm more in favor of the loop with a headlamp. But regardless of what we are comfortable with, having a good magnification and illumination is necessary because we are working in narrow surgical corridors. The third T is technique. So the technique that you use is influenced by your operative background, who your mentors are, and the type of training that you receive. The fourth T, and a very important one, is training. Most of the panelists who are with us represent the first generation of MIS surgeons who have learned many of these techniques on their own or have shifted from open to MIS procedures. Like Dr. Ayush Sharma mentioned, he started off with open, then went on to tubular, and is now learning endoscopy. But this is something that they have learned and experienced on their own over a period of many years. Fortunately, for a next generation MIS surgeon, we have been fortunate to get exposure to MIS cases during our fellowship year. So that also sorts of helps us in bridging the initial learning curve, the learning through the experiences and mistakes made by our mentors. The fifth T is testing. So testing is a critical review and analysis of your own cases. There is no better teacher than your own mistakes. We seriously mend all records and try to publish whatever we learn through our experiences in MIS. So that helps us in critically analyzing our own functional outcomes and improve from it. The last T is unfortunately something that cannot be taught, and that is talent. There are several surgeons who are naturally born with a keen understanding of 3D anatomy, who are naturally ambidextrous, and they definitely will have ease in mastering this initial learning curve. So these limitations of MIS surgery are already being challenged. I'm sharing a few studies performed by some of my mentors. Herein, this is a study by Dr. Ayush Sharma, wherein this is a conjoined nerve root that has been present, but it has been tackled through a tubular approach. With regards to endoscopy, this is a very interesting and very nice article which has spoken about standard indications of full endoscopic surgery by Dr. Ajay Krishnan, and this study was done at Stavya Spine Hospital, Gujarat, wherein he talks about use of endoscopic surgery in calcified discs, in cauda equina syndrome, and some of the other potential contraindications, including a technique description of the same. So these limitations and potential contraindications are every day being challenged through experiences of these surgeons, along with rapidly advancing technology. So to conclude, the current state of MIS surgery is such that we anticipate continued innovation of new techniques and expansion of indications of MIS. So MIS is here to stay, and this learning curve and these potential contraindications will be challenged in the coming years. For a beginner surgeon like me, one thing I can say for sure is the MIS surgical path appears like this, wherein your plan appears like a smooth sailing, but a reality, even for simple cases, is it is fraught with multiple obstacles in between till you reach your goal. So appropriate planning, taking assistance of technology, discussing cases with your seniors is something which I'm adopting these days in order to overcome these obstacles. Thank you, everyone, for a patient listening, and I'm open for any questions. Thank you.
Nice. Good, very comprehensive talk. Dr. Marathe, right?
Yeah.
And so in terms of, you pulled out a really nice data review. And so what are the easiest steps to navigate from open to MIS? I know, talent, describe technique and targets. And what kind of a sort of a, lesson you're going to give to someone who is really want to develop into more MIS techniques? What is your treatment paradigm that you typically use to sort of prioritize your MIS techniques? And in general, do you still practice as an open, or you just prefer to use MIS and then try to gear more towards MIS surgeries moving forward?
So coming to the first part of the question, that is shifting from open or navigating your early learning curve, one of my mentors actually suggested, and this is what I'm doing in current practice as well, even for a surgery that is a planned open, we try to put in the docking tubes and try to perform the surgery through the tube, though it's an open surgery. So at the end of the surgery, you can always go back and see what's going on. And I suggest docking of the tube even in planned open surgery. Currently, there is a plethora of online courses, including some from AO Spine, as well as plenty of videos that are available online, which can help in keeping abreast. Participating in conferences, live cadaver courses, and continuously trying to upgrade yourself is what I'm planning to do. So currently, my practice consists of mainly open surgeries, and I'm still not crossed my threshold of 100 MI surgeries. But for any case, we try to give a thought as to whether it can be tackled in the MIS way, and the goal is to evolve from open to MIS in the coming years.
Great, very good. I think you have a great approach. I like that.
The other thing that we are doing for the initial cases is we are being very open with the patients, and many times we consent them that there is a line mentioned that we may require conversion to an open procedure, which fortunately hasn't happened so far. But we do tell them that if it's like an extended indication or something which may not be tackled easily, but the patient is very keen on MIs, we always mention that there may be a possibility of converting it to an open procedure just to be safe from the medical legal standpoint.
Absolutely, that's fine. Yeah.
Well, thank you again for the fantastic presentation. I can give you a statistic about United States that about 50% of the surgeon here identified themselves as open surgeon, and about 40% of the surgeon here identified themselves as they are performing MIS procedures, and the definition is so practically so variable that for example, some surgeon, if they perform ALIF, they still consider that as a minimal invasive. So there's not a really good definition, and it goes all the way that there are some surgeons that they identify about, actually in the United States, less than 15% of the surgeons identify themselves as exclusively minimal invasive performing surgery. And if you look at the numbers now, by numbers, regular TLF is still 80% of the fusion in the United States is performed that way. Now, for microdiscectomy, the number is probably going half-half, approaching half-half. That half of the surgeon perform microscopic, much less endoscopic. But what would you say, considering that the numbers that I just gave you, about generally, I would say probably less than 25% still in 2022 of the surgeries in the United States are done truly with the MIS technique. What would you say in your geographic region, what that number is? What percent of the surgeons are still doing old-fashioned surgery versus MIS?
So with regards to this question, in India, there is a great divide in between the cities and some of the rural areas. In some of the metro cities like Mumbai and Delhi, there is a plethora of MI surgeons with all the available technologies at your disposal, whereas in some of the rural areas, even access to a C-arm may be difficult, and there are surgeons operating with portable X-rays. So many a times, the challenges with regards to acceptance in 2022 are more with the logistics rather than the desire to be an MI surgeon. In some areas, and the type of setups that we are in, adapting these techniques is difficult, though the surgeon himself may be keen to do it.
So the burden in your geographic region is our resources, mostly the resources, and the technology is concentrating in at least the MIS technology in more metropolitan, bigger centers, bigger hospitals. I have noted in the United States that the technology is not really the limiting factor. It's actually the surgeon's desire and the surgeon's previous practice and education is the most of the problem to practically perform MIS surgeries. And there are truly half of the surgeon, literally they say they just don't believe in MIS in the United States, even in 2022. So the actual burden I see in the United States mostly being the surgeon themselves. Whereas what I understand you that it's more the surgeons are more open in your geographic region to the new technologies, but the resources are the limiting factor. Is that correct? Do I understand it right, or?
Yeah, that's right. I think the adaptation from the surgeon's end is not really a problem. And if Agarwal sir is also here live, and I may ask his opinion as well. In your experience, sir, what do you think is the barrier? Because personally, I feel that surgeons are very open to adapting these techniques and are keen to learn, but are usually hampered by economic challenges or the lack of facilities.
Yeah, that is true. Absolutely. Even the patients are more keen to get operated in a minimally invasive way. The amount of education among the patient is phenomenal here. And even they are very keen, and they have a very big inhibition of these traditional spine surgeries because they have seen patients in their region, in their villages, in their hometowns, in their localities who have had these kind of big surgeries and they have not improved over a period of time or have been bedridden even. So that is a very big kind of a mindset in the patient that when you say that I will do a minimally invasive surgery, I will let you go home the same day, I will do it with a small incision, I will do under local anesthesia or general anesthesia, whatever. But nobody wants to stay in the hospital for the long time. That has been my experience. I personally practice in a tier 3 kind of a city. I'm not in a metropolitan, but the acceptance of patient for these minimally invasive techniques is quite good. And even for the surgeons, even then they have started realizing that these techniques offer much more value to the patient than the traditional surgeries. It is the only limitation is the access to proper training and access to some part of technology, I would say, because like Dr. Abbasi has shown, his kind of a technique doesn't require anything more than a Shyam. Yeah. And Shyam per se, I would say, is a basic requirement of any spine surgery. If you don't have a Shyam, I would say, then thinking about minimally invasive is very difficult. You may not have those fancy microscopes or fancy robots or fancy kind of, gadgets. They are more for the surgeon comfort rather than, do anything exclusive with them. There are only certain criteria segment of patients who would actually benefit from those kind of techniques. Like I showed you in my presentation, those are one-off cases. These are not my everyday kind of cases. It is just to show what the technology can offer. It is not required in the majority of the patient, and they can very well get operated. So my practice over a period of time also, even though I have access to all those gadgets, has gone towards endoscopy and gone towards minimally invasive and local anesthesia because the patients are giving better results with these kind of technologies. That's what we have to understand. And the older school of thought has a difficulty in understanding that these techniques work. But when your patients come back much more happy, and like Dr. Ayush showed, and we all who are doing minimally invasive, we had our own open cases which have been revised using minimally invasive techniques, or other patients by other doctors who were earlier operated by these big open surgeries have been revised with other pathologies or recurrences with minimally invasive techniques. Those patients actually tell you what difference they have experienced in terms of recovery, going back to work and things like that.
Well, I think that is a good kind of conclusion that I think we can come all together here. Here in the United States, even though we always complain about the economy and so on and so forth, in truth, we have, like Dr. Janju or Dr. Gupte, have access through the hospital to these technologies. And it is practically, it's a good addition to what we can do. But I think in many parts of the world, considering that the population is getting older and this care is required more, we always have to, as well on the highest level, include the resources that is needed for new technology. And as we talked about, that yes, you do need a certain level of expertise and a certain level of technology and resources. And I have noticed in our part of the world, the skill is abundant. The problem is the technology, and you would be surprised what percentage of spine and neurosurgeon and orthopedic surgeon here in the United States are from our part of the world. So, and that is a truly has been amazing experience here. In our group, 80% of our surgeon that are coming either from India, Pakistan, South Asia, and even Africa, and these skills are have to be obviously trained, and considering that in many of these techniques we can modify them to use less resources. That makes me really excited about moving in that direction. So I'm hopefully in 2022 we can have a lab organized in India, and I'm really happy to bring this technology. And again, on the side of the hospital, there is need for 2 C-arms for my technology, and but on the other side, instead of doing 2 surgeries a day, then you can do. In next week, I'm doing 6 surgeries a day in 3 days a week. So I'm doing many surgeries. Even though we use 2 C-arms, we expanding the capacity of the OR, and in truth, just a small tray is needed. And as well, we have connected to some hardware manufacturers in your geographic region, where they think they can. We are happy to literally give them all the designs and so on, so that as well the technology can be produced locally. I think we are sitting on a truly pivotal moment in the spine, because generations, as we looked at in one of the slides, our population is getting older, and with older population, we are dealing with the public health issue regarding healthcare and spine care. Many of these patients, they become dependent on the family, and that has impact on the economy of the country. If the whole family has to take time off to take care of the parent, rather than performing a procedure that can make the patient independent and pain-free. In the United States, we noticed that the annual impact, we did one of our first paper was an economic paper that shows I didn't show that slide, but the annual impact of going from open surgery to minimal invasive in 2015 was $3 billion with a B annually. And this is just a perioperative saving, meaning less time in the hospital, less time in the OR, less infection, and less return to work. And that paper has been published in 2015. That was $3 billion. This didn't even include the time off work, time that the family have to take time off to take care of the family members. So I think with the bringing the entire cycle of the technology, including hardware, production, and so on, to places that is our home, our original home, I think we can go in a direction that the phone technology has gone. In the phone technology, in many countries, they went from no phone to cell phone. They completely went over the landline technology, because the cell phone was more available, easier to maintain, and so on. And I think in many of the part of the world, we can go directly from very little spine care to highest level of spine care by eliminating this, what still in the United States is 75% of the care, which is open surgery that literally put the patient on a 1-year recovery path. So that is unsustainable in United States, and I'm sure we can do some good work there to bring this technology to our original home. So it has been a very productive meeting. Please, if anybody has a suggestion, comment, and so on, please come forward. I really want to thank Dr. Yogi and Amanda Armagos that put this meeting together. And I'm truly hoping that we continue this maybe every 6 months, or at least every 6 months we can get together. And I'm truly hoping that Dr. Yogi and the rest of the team can organize a lab meeting, that we bring the technology and we train local people in local place. And as well, as soon as the requirement for the travel are eased up, I truly invite you to come to us. Let us show you as well this technology here. Again, Dr. Yogi and Amanda will help you on that. So this is my final comment, and I welcome final comments on the side of the participant, and I thank you all.
Thank you very much. Pleasure.
Thank you for the very nice.
Thank you.
Thank you. Thank you.
Okay,
thank you.
Thank
you very much.
Thank you all. We conclude the meeting then. Thank you, all of you.
Thank you very much. Have a great day.
Bye-bye.